and reactance. Reactance is denoted in the form of X. So reactance at 5 Hertz, reactance at 10 Hertz, reactance at 15 Hertz, and reactance at 20 Hertz. We also get R5 minus R20. Now what is R5 minus R20? R5 is the resistance in the total airways. R20 is the resistance that is measured at the larger airways. If you subtract R20 from R5, you would get the resistance in your smaller airways. Then you also get resonant frequency, also called as FRES, and area of reactance, which I will explain in the next slide. So what you see over here is a graph in which you have reactance and you have resistance. The line that we see, is this a pointer?
Yes, madam.
Okay. So the line that we see over here is the resistance. Now this is that of a healthy individual. What you see over here is resistance, and on your x-axis you see the frequency of the sound of the pressure wave. So what you see over here is, as the frequency of the pressure wave increases, the resistance remains the same, which means resistance is frequency independent, whereas reactance is inertance plus capacitance. So in a healthy person, the reactance at the beginning is slightly at the negative. So if you see on the x-axis, on the y-axis, you have reactance in negative. So in a healthy person, at the beginning it's in the negative area, and from the negative it goes to the positive. This point where the reactance is going from the negative to the positive is called the resonant frequency, also known as FRES. And this area is called as area of reactance, also known as Goldman's triangle. So like I mentioned before, that your capacitance is dominated in the smaller airways and your inertance is dominated in the larger airways. So this is your area of inertance, this is the area of capacitance, this is your area of reactance, and resonant frequency. Resonant frequency is the point where your reactance goes from the negative to the positive. So this is how a report or a graph of a normal person would look like. If you look for severe, moderate and mild resistance, this is what you will get. What you see over here is that of a normal person. The resistance is more or less the same. Whereas a person with mild obstruction or mild resistance, you will have the resistance at 5 Hertz increase. Whereas for severe and moderate, you have the your R5 is highly increased in resistance. In reactance, what do we see? That of a normal person, your FRES, your resonant frequency, lies between 6 to 12 Hertz, and your area of reactance is very small. In the negative, it's a very small area. In the mild, moderate and the severe, what you see is your FRES has increased and the area of reactance has also increased. That is, the area in negative has increased. So this is how you distinguish between a healthy versus a person with resistance. In small airways obstruction, what do you see? You see the Goldman's triangle, or the area of reactance is much smaller. FRES is between 6 to 12 Hertz, whereas in small airways obstruction, your area of reactance has increased and your resonant frequency has also increased. Your R5 is also increased. So the parameters that increase in small airways obstruction is R5, R5 minus R20, AX and FRES.
Dr. Disha, since we have lack of time, you just go ahead for whatever clinical applications are there.
Okay, so I'll go to my last slide. Okay, so if you have in normal airways, you will have a normal resistance and a normal reactance. In damaged alveoli, you will get a normal resistance and an elevated reactance. In airways obstruction, you will have elevated resistance and normal reactance. Airway obstruction and damaged alveoli, you will have elevated R and X both. What you see over here is, in a study which was evaluating whether IOS or lung oscillometry parameters are good enough to identify whether to administer biologics, it was found that FDR percent, that is R5 minus R20, small airways, the accuracy was found to be 79%. Even for pheno, the accuracy was found to be 76%. Only blood eosinophil gave an accuracy of 64%. FEV1 gave an accuracy of 44%. So what can we conclude from this? Lung oscillometry indices are a better predictor of small airways dysfunction and severe asthma than FEV1 or blood eosinophil count. So spirometry is not a reliable predictor to decide the use of biologics. Lung spirometry indices are more sensitive to detect therapeutic improvements in severe asthma receiving biologics compared to spirometry. If you look at the box and the whisker plot over here, with the increase in the severity of asthma, we see a sequential increase in small airways dysfunction, which is measured by the IOS and not by spirometry, which is not picked up by spirometry. In spirometry, it is picked up only in step 5. So the sun is starting to set for spirometry in asthma monitoring, whilst a new dawn with FOT will finally bring greater clarity to the physiological domain of asthma. Thank you.
It was very nicely dealt by Dr. Disha, but it was more of a physics aspect of sound impacting the lungs, airways as well.
I'll talk about eosinophils and serum Ige. You've heard parts of the chapter of small airways disease, inflammation, etc. with the talk on pheno and on impulse oscillometry. So I'll give you a perspective about eosinophils mainly, and I'll touch on serum Ige at the very end. So eosinophils are multifunctional cells, and they react beautifully to the microenvironment. And in reacting to the microenvironment, they have functions both in disease process and also in body defense mechanism. There's a plethora of activity that eosinophils might have, which are depicted in this slide, and I won't drag you through this simply because I don't understand them very well myself. Let's try and make them simpler for you. So when we talk about eosinophils, we talk about two basic facets. We said they act in health and they act in disease, and the inflammatory component of eosinophils, which we all know about, hear about, is the disease aspect of it. And you know that they have an important role to play in asthma phenotypes, but airway inflammation is responsible, with eosinophils is responsible for other disease processes also, and I'll come back to them in a minute. The more interesting aspect of eosinophils is what's been termed as homeostatic eosinophils. And these are ones which are related to the immunity, but they have other functions like metabolic hemostasis, they have anti-tumorigenic roles, we all know about the parasitic protection effect, and gut immunology. When we talk about biologics going forward, and we hear Dr. Deepak Talwar talk about this later on today, it's this balance between the inflammatory eosinophils and the homeostatic eosinophils which is important. So which one takes precedence? Is partial depletion of eosinophils better as compared to complete depletion? Does partial depletion mean you're only depleting the inflammatory eosinophils and maintaining the homeostatic eosinophils? I think the jury is still out on the answer to these questions, and with drugs like benralizumab, which cause complete depletion of eosinophils, versus mepolizumab, which causes partial depletion, we will get answers going further forward. So we said that asthma is the disease where eosinophil has the greatest and most complex pathophysiological role. However, there are other diseases on that particular slide, and again I won't drag you through this list, but some are important. EGPA we've spoken about this morning, chronic rhinosinusitis with nasal polyposis, hypereosinophilic syndrome, eosinophilic COPD, ABPA. There's a whole host of illnesses in which eosinophils have a pathophysiological role. And you see the red circles are down there. The red circles are where the treatment, the anti-eosinophil biologic treatment, have been proven to be useful, but that's another chapter for later on today. So Nagarjuna told me to answer certain questions rather than talk just about eosinophils. He's asked me to answer certain questions. Some of these questions are more hypothetical, to which there's no evidence-based answers, but I'll try and put up these questions and give answers which in my understanding and reading of literature is the way things should be. So the first two questions he posed for me are sputum versus serum eosinophils, and is there still a place for sputum eosinophils to be tested? And the second was the variability of eosinophils. We talk about eosinophils at a single point. Are eosinophil constant numbers in our body? Is there only a small variation, or is there larger variations that are present, and is variability in individuals a challenge when we check for eosinophils in subjects? So let's start off a step further on. When we talk about type 2 biomarkers in asthma, we are talking about type 2 cytokines which trigger the inflammatory process. And in triggering the inflammatory process, there are various cytokines, and I've named two on there for you, interleukin 13 and interleukin 5. Interleukin 13 is responsible for the secretion of periostin. Periostin in the airway goes into the bloodstream, and you measure plasma periostin, which is the marker of inflammation, and you heard Dr. Uma Maheshwari mention this in her talk. The second pathway is with interleukin 13, induction of nitric oxide synthetase, which results in increased amount of pheno, and pheno can be measured in the breath, and you heard an entire talk about this. Interleukin 5, on the other hand, induces inos, but it also causes eosinophil migration into the airway lumen. Hence, eosinophils can be measured in the sputum. They also increase eosinophils in the bloodstream, so you get blood eosinophilia. They also act on the bone marrow, and this induces eosinophil maturation. So the question we are asking is the eosinophil in the airway a fair reflection of the eosinophils which are measured in the blood? And I'm going to try and answer that question for you in the next couple of minutes. This is a lovely paper which looks at blood eosinophils and pheno, and whether it's a reflection of type 2 inflammation, and whether it corresponds to a diagnosis of sputum eosinophilia when sputum eosinophilia is diagnosed as being more than 3% eosinophils in the sputum. So pheno, blood eosinophils, and how they correspond to a more than 3% sputum eosinophilia. So that's a receiving operator characteristic, that's a ROC curve, and you can see that blood eosinophils in red on there corresponds very nicely to type 2 inflammation in the airway. What about pheno? You see, pheno also is a fair representation. It's not as good as blood eosinophilia, but it's a fair reflection of type 2 airway inflammation. What about periostin? And I think periostin probably is not reached the stage when it can be used by itself to characterize type 2 airway inflammation. So that's the ROC curve. Good corresponds well with blood eosinophilia and to an extent with pheno. This is the more clinical paper, and I want you to focus on this bar diagram. So look at what we are looking at here is eosinophils as a determinant of exacerbation risk. You can see there are two parameters that are being measured: prevalence of asthma attacks and prevalence of asthma-related emergency department visits. The two parameters we are measuring are blood eosinophils and exhaled nitric oxide. I want you to focus on blood eosinophils first, and you can see that with asthma attacks and with asthma-related emergency visits, the eosinophil count has a very nice linear correlation. So higher the eosinophil count, greater the exacerbation risk in these individuals. What about pheno? Pheno comes a very poor second in this aspect. It's not a very good parameter as far as predicting exacerbation risk is concerned. Dr. Uma Maheshwari did show you a paper where there is a hint. However, you can see that the hint or the trend is not half as good as what you see with blood eosinophil counts. This is a roadmap. It's like the London Tube map, which looks at various aspects of asthma. You can see type 2 asthma on there, you can see IgE, and it looks at various biologic agents and their pathways in which they act. That's not the point why I show you this slide. The reason I show you this slide is sputum eosinophils and blood eosinophil seem to have similar indication as far as predicting type 2 asthma is concerned. So maybe we can use one or the other equally effectively is what this roadmap depicts. This is from one biologic, the DREAM study, and it looks at potential predictors of response to the biologic. But rather than the biologic itself, I want you to look at these predictors. It looks at sputum eosinophils, and you can see that it's a reasonable predictor of response. However, blood eosinophil count with a cutoff of 150 cells per cubic microliter or a 300 as a cutoff, both of these seem to be the best predictors of response when you're measuring a response to a biologic, which is mepolizumab in this particular case. There's also exhaled nitric oxide, atropy, etc. And exhaled nitric oxide also seems to have an effect, but the best effect seems to be with blood eosinophils. So blood eosinophils work. They tell you about type 2 inflammation. Is there a place for sputum eosinophils? So one of my colleagues in Kolkata, Dr. Ungira Chatterjee, is one of the greatest proponents of sputum eosinophils. And in making this slide, I had a conversation with her as to where she uses sputum eosinophils in her clinical practice. So she says that it's not a routine part of existing asthma protocols, except when it's used as a research tool. It's not difficult to perform for her, it's not difficult to perform for Dr. Salvi, but for general clinicians, I think it's a challenge for us to perform it on a routine clinical basis. There is, however, no definite correlation between blood and sputum eosinophils in severe asthma. And I'm stressing on severe asthma because there seems to be some correlation in mild to moderate. This is a paper from Angira's group which shows the lack of correlation between blood and sputum eosinophils. You can see the scatter diagram all over the place. So there is no correlation between blood and sputum eosinophils in asthma in this particular study. So the potential indications are severe asthma which are prone to recurrent exacerbation. And in the red italics on there, I've put for you certain indications where you can think of sputum eosinophils if you have access to this tool. So phenotype of eosinophil asthma, blood eosinophils are not giving you a definite answer. So just to jog your memory, what's the phenotype of eosinophilic asthma? So that shows you the phenotype of eosinophilic asthma. It's normally late onset, equal gender distribution. There's a high risk of severe exacerbations. They have low FEV1. They have rhinosinusitis with nasal polyposis, and they're aspirin sensitive. So if you have all these characteristics, but your blood eosinophils are dubious, they're not giving you the correct answer, doing sputum eosinophils might be something which is useful. The second area where you can think of sputum eosinophils is when you're trying to start off with an IL-5 antagonist, or you're shifting from one monoclonal antibody to another. A sputum eosinophil might be useful in that scenario. In some patients where you cannot wean the patient off oral steroids, they have maintenance oral steroids, and they're getting recurrent episodes of oral steroids, it's something that you might want to do. The second question that I was trying to answer is the variability of eosinophil count as an asthma biomarker. And thanks to Nagarjuna, I came across this lovely study which looked at about 80 odd blood donors who had 4 separate blood counts done 8 weeks apart in the scenario of doing blood donation. These are all patients who had some form of allergy, and they were labeled as having asthma alone, allergic rhinitis plus asthma, or allergic rhinitis alone. The eosinophil counts were the highest in patients who had asthma alone. So that's the count on there, 250 odd cells is what they found. In allergic rhinitis plus asthma, it was slightly lower. In patients who had allergic rhinitis alone, the count was far lower at about 170 cells per cubic millimeter. In the individual subjects, you understand each of these patients had 4, each of these individuals, not patients, had 4 counts done. There was a geometric coefficient variation of about 40%. So the eosinophil counts varied by 40% in the same individual depending on the time at which you did these. If you had 150 cells as the cutoff for these individuals, 57% of patients, individuals exhibited eosinophil counts which were above and below the cutoff. And I'll show you this, the scatter diagram. So the green dots are the individual patients. The line here is for 150 cells, and you can see more than 50% of individuals had eosinophil counts both above and below, showing the variation in eosinophil counts in individuals. The blood eosinophil, so seasonal allergy and inhaled corticosteroids in this study had little to do with the variability, but you remember that this study was done with few number of patients, there were only 80 individuals in this study. So what's the carry home message? Why am I showing you this cell? All of the studies that have been done with monoclonal antibodies show that one single count is important. However, remember, variability is important, and maybe serial count of eosinophils are far more important as compared to a single count of eosinophils. The next question is about whether absolute eosinophil counts is the same in the Indian and the Western population, and can we use the same cutoffs? Now, this is a question that I get asked most often. Unfortunately, I won't be able to give you the right answer. However, important to think that the range of factors that include blood eosinophils are many. And while asthma is the greatest odds ratio in increasing blood eosinophils, smoking, positive skin prick testing, COPD, male sex, metabolic syndrome, the list is long. You see comorbidities in the way of hypertension, heavy smoking, diabetes at the bottom. So all of these factors can have an impact on your eosinophil count and increase it. And this was a lovely study which looked at all these confounding factors, and if you took these confounding factors out of the equation, the risk factors out of the equation, 100 cells and less was normal eosinophils in populations across the globe, across the world. What about the Indian scenario? In the Indian scenario, when we did a literature search for our eosinophil study, which we are doing at the moment, we found about 16 studies which looked at eosinophil counts. However, all these studies were single center studies, various parts of the country, but single center studies with less than 1,000 patients. This one study I've quoted here from rural part of South India. With the permission of the chair, I'll take 2 more minutes. Is that okay? So, the rural part of India, which showed that the mean eosinophil count was 320 cells per cubic millimeter. We started a study with Dr. Sandeep Salvi's group last year, not 2 years ago actually, where we recruited about 1700 patients and the count was about 220 cells per cubic millimeter. We've got an ongoing study between 2 different cohorts and we'll hopefully have 10,000 patients between us. However, my take is that eosinophil counts in its Indian population will be reasonably similar to what we have in the Western population. What about serum eosinophils and the effect of high-dose inhaled corticosteroids? So this looks at eosinophil counts in patients with ICS. You can see the inhaled corticosteroids used on the left, on here. Those are the various doses. You can see the counts of eosinophils and the percentage reduction on the left. So irrespective of which inhaled corticosteroid you're using, with high-dose inhaled corticosteroid, the reduction is to the tune of 50% when used over a 3-month period. So eosinophil counts do come down with inhaled corticosteroid, and this shows more of the same in patients who start off with a raised eosinophil count and are on a medium dose ICS. When you shift to high-dose inhaled corticosteroids, the eosinophil counts come down significantly. So, last 2 minutes, speak about IgE in asthma. Atopic asthma is a subtype of extrinsic asthma in which patients have hyperresponsive airways. These airways need to be sensitized with an inhaled or a chemical antigen to start with. They stimulate the induction of Th2 type T cells, which release cytokines interleukin 4 and interleukin 5. These cytokines promote IgE production by B cells. The study that I quoted at the bottom from India showed that the mean IgE levels range from about 150 international units per ml in normal subjects, about 750 in healthy subjects, and about 1,000 in patients with severe asthma. So there is a trend in that normal subjects have an IgE level of mean of 150. This is a single center study again, but gives you some clues about IgE levels. Mild asthma is about 450 odd, moderate is 650 odd, and severe asthma in this particular population is about 1,000. However, this study showed that IgE is a biomarker for severe asthma, but it's not good at exacerbation prediction. So it does not help in exacerbation prediction, unlike what we said about eosinophil counts. So IgE is used to assess asthma and atopy. Allergen-specific IgE can be used for identifying atopy, however, its presence does not equate to an allergic response. Specific IgE can be measured by a skin testing or serological test. However, calculation of anti-IgE, it does not predict treatment response, it only helps in dosing. And it's not a predictor of exacerbation risk. So I finish off by saying that eosinophils are multifunctional cells. They help in both health and disease. The proportion of these are still not definite. Measurement of blood eosinophils is generally enough to define Th2 inflammation. Sputum eosinophils, as of today, have limited value. IgE is useful in defining atopy and predicting the dose when you are trying to prescribe some of the biologics, and increasing eosinophils is useful in predicting exacerbations, but IgE levels do not have any such value. Thank you very much for listening.
Thank you, Dr. Raja. One or two questions, quick.
Raja, just one question.
Yes.
So when we have a normal eosinophil count, after how many weeks do you want, is it correct to repeat a count just to make sure that we're dealing with the correct count?
So I think
how much is the variability per week or per day or per month? Do we have any data for that?
So there's only one study that I quoted. This study did the eosinophil counts about 8 weeks apart, Nagarjuna, and they found a variability of about 40%. Right? So the recommendation would be to repeat it after 2 to 3 months. If you have a patient who is completely stable, and if you've managed to get the eosinophil count in that state of stability, and the patient isn't a smoker, there are not a lot of confounding factors, maybe 1 eosinophil count is also sufficient, but in others you would want to look at a trend, and maybe 3 months would be the right sort of time to do that. It's also useful. Yeah, it's also useful to look at historical values. So if you've got a eosinophil count from 6 months ago, a year ago, it's better to go back to the file and look at those numbers. They also help. Sorry.
Yeah. So, rather than the last slide about exacerbation risk estimation. Recently, while I was preparing for my presentation, I came across this oracle. It's a scale. Yeah? So they're talking about not just blood eosinophils, but pheno also.
Yes.
Maybe there is a role of pheno also in predicting the risk of exacerbation, not just in severe asthma, but even in mild asthma also. That's where use of steroids will come into play to prevent an exacerbation, even in mild asthma. And pheno, as they say, it reflects something inflammation in the airways, airway compartment. So eosinophils reflect systemic compartment. So two compartments that we are dealing with, and then this estimation is like.
So very fair comment. Very fair point. I think these investigations go hand in hand rather than being one or the other. I think if you sort of club them together and look at them holistically, I think you get a better picture, like you said, of both the airway and the physical.
It's like blood sugar and triglycerides for acute coronary disease. So maybe we have to look at all this
together.
Now, last question or comment from Dr. Vishwanath.
Thank you, Dr. Raja, for the nice talk. You were mentioning about a study about the eosinophil count in Indian population. In the last, you mentioned about 244. The 244 was the mean eosinophil count in the Indian population.
So the 244, the 254, the 244 and the 170 I quoted was a global study. For us, when we did it, it was about 220 cells in a small cohort of patients that we did 2 years ago.
Normal individuals.
That's right.
Normal individuals.
Right.
And in the last, you also made a comment that the threshold for giving biologicals in Indian population should be the same. Because you are saying that on one hand, the eosinophil count is slightly higher at 220 or so.
Sure.
So can we really take a threshold of 150 for giving biologicals?
So I think we take a threshold of 300, Vishwanath. So I think that will be our threshold for the time being. The 150 is at the point of one. You know, we do two levels. We do a 150 and a 300 separately. So for us, I think across the board, when we are prescribing biologics, we take 300 as being the value rather than going to the 150. But we will have data in the next 1 year or so. For
Thank
sure.
you very much.
Thank you.
Yeah.
Thank you very much.
Thank you.
Thank you, sir, for the lucid and informative talk. May I invite Raghutam Reddy, sir, to come on the dais to present a small memento to our speakers and chairpersons. Dr. Rajadhar, sir, please. Dr. Disha Gorpade, ma'am. Dr. P.L. Swami, sir, please. Dr. Matinuddin, sir. Thank you, sir. There's a small change in the order of events. We will be having session 3 after some time. We will now proceed to the opening ceremony and inauguration of asthma clinics. May I invite on the dais our guest of honor for the day, Dr. Pavan Gorukanti, sir, Director of Yashoda Hospitals. I would request our chief guest, Dr. Subhakar Kandi, sir, to join us on stage. Sir is currently the chairman for ICS South Zone and is among the senior most pulmonologists of Hyderabad. I now invite Raghutam Reddy, sir, senior consultant pulmonologist at Yashoda Hospital, to come onto the dais. I would request Dr. Nagarjuna sir to come onto the dais, who is the course director for this event today. I would request Mr. Karthi Hevalan sir, who is the unit chief, to come onto the dais. May I also request Dr. Rajadhar sir and Sandeep Salvi sir also to join us on the stage, please.
Hey, sir.
Now may I request the dignitaries on the dais to inaugurate the Severe Asthma Summit 2021 by lighting the ceremonial lamp.
So one photo first. This camera. Photos first. Okay, ready, sir?
As the lamp is being lit, I think I just also talk a few words on the concept and approach to the whole pulmonology as such. I think they've come, I was talking the same thing in the morning before we started the session also. Pulmonology as a specialty is progressing leaps and bounds, and I don't think there are words to talk about the pace at which the developments are happening in pulmonology. So I think at this juncture we have come to a position where pulmonology is not one specialty. It is a group of specialties, and each disease would merit to be called a specialty in itself. So this is the reason why we have also started this concept of specialty clinics, so that people, yes sir.
Closer. So we ready, sir? Yeah, one more. Everybody smile.
So the concept of this specialty clinics is that the patients will get better benefit from a very focused approach, and with this thing only we have recently soft launched the severe asthma clinic, and then we will be officially launching the severe asthma clinics from today. And I would also request now Dr. Pawan sir to say a few words, and then Dr. Subhakar and also to say a few words.
Thanks, Pradeep Nagarjuna. It's a great effort to organize a wonderful session within 10 days or so, despite the festival season, Dasara and all, for organizing people here, and more importantly for all the delegates from all over the country and the world, and even more important for the students and for all the pulmonologists who have come from distant parts. Despite being a long weekend in India, we get very few of these long weekends, I think. US was different. When I was in Michigan and all, my work schedule was 1 week. If you work, you can take 1 week off, that kind of schedule. So we used to have a lot of time this way, but Indian doctors' schedule is from morning to evening, and even these weekends, festivals, everything, they're putting in extra efforts and came in here. I'm sure you'll go much more enriched. Nagarjuna was telling, yes, pulmonary is a good field. So not only the branch itself is good, so if you ask me on my other hat as an administrator, in this last 1 or 2 years, if you see that 1000% growth is only in one department, and it's pulmonary, and I think so. So you have done one thing, selected the right field, and yes, the second thing is coming for these sessions like this to keep you updated. Nowadays there are so many doctors graduating from the country that there will always be a place for, if you distinguish yourself, you have to be ahead of the curve in both academics and the latest techniques, and also the sessions like these, you came and you will go much more, and this will help you be the leaders in the field. Patients will automatically follow once you do advanced work. So, all the luminaries is there in the front rows here. So these two things, you have selected the right field, you are doing the right things, and if you want to come here to this front benches, the only thing left is to still we need to do a little more. First of all, publications too. These will be very important in the future. If your Google search on your name and all, automatically some publications should come on yourself too, so that people will recognize. Nowadays publications and academics is the future, and it's not that tough to I was just telling the other day in some conference with Dr. Gangadhar, it's one day I could do some 6 or 7 case presentations. I realized that it's not that time. Even for this chest and these kind of things, sometimes it just needs a good name to one of my publications was just in hypothesis, I am Superman, hypothesis close, hyphen, psychiatric manifestations as an initial presentation of lung cancer. So that patient had a tumor and he ended up in a psychiatric ER, and they were treating him for psychiatric things, but eventually turned out to be lung cancer with metastasis. But partly it may depend on the name of the thing, and all these luminaries here will advise you how to do publications, case presentations, publications, and these kind of things should be on your CV, so that you will be invited on stage and you will be the next generation leaders too. So anyhow, I don't want to take too much of your time. This is a wonderful session about, today we are focusing on asthma, but the team here will be responsive if you have any questions in anything from COVID to anything in pulmonary. But asthma, as you know, has advanced quite a bit. When I was doing my MD general medicine in Manipal, pulmonary was, they used to say only tumulu dagulu, only cough and sneezes used to treat. But nowadays it's changed so much. Actually the maximum, I'm very excited by this, Nagarjuna and all is popular otherwise too, but and Facebook and all nowadays is, it's mainly for the professional purposes. It's popular with the ladies and all, but not for these things too. So all of you have to be on social media too, and you need to get yourself known professionally. Not only Facebook, LinkedIn, and all of these things are required. Sorry, I'm taking too much of your time. I think today, asthma from top to bottom, including the monoclonal. Bronchial thermoplasty, basics. First of all, how to diagnose, what is this FeNO, oscillometry, and all of these things you should be aware. You may or may not do these things, but better to be aware. And each of these things, whichever finally you want to specialize in, either asthma or COPD, ILD, transplants, any of these things, you need to be ahead of the curve. And you are doing most things right though. You selected the right specialty. You are coming to the conferences like this, only that next 1 or 2 things, and you will be on the stage here too. Thank you.
Thank you, sir. May I request Subhakar sir to come on the dais and say a few words, please.
Yeah, good morning. Dr. Pawan and Dr. Nagarjuna and my colleagues from the Indian Chest Society, Dr. Rajadhar and Dr. Saudi. I bring warm greetings to this meeting from the Indian Chest Society also. In fact, 1 week back, Dr. Nagarjuna called me, almost one week back. I am in US. I am hosting a meeting on Sunday, sir. You must be there and you must give permission from South Zone. to host this meeting. I said I will be there. I reached yesterday at night 2 o'clock from US. Actually, I have one more meeting at Asian. I'm supposed to go to Nageshwar Day. I said, I'm sorry, I committed to Dr. Nagarjuna. So in fact, the last 1 month after this COVID pandemic, I must congratulate Yashoda Hospitals for conducting 3 events, all from the South Zone. They conducted an excellent South Zone PG meet, Dr. Gangadhar Reddy has conducted. And before leaving to US, Hari Krishna conducted a simulation center. I think they are keeping the Yashoda Hospitals in the international map and in the field of pulmonology. I think I must really congratulate. Without saying, this is all the encouragement given by our young friend. Without his encouragement, they are not conducted this. He is very young, dynamic, always there for the meetings. He always comes, encourages the pulmonology department. He gives, boosts the morale of the pulmonology department. I think because of your efforts, the pulmonology department is doing well. After hearing today's excellent lecture from Sandeep Salvi, the Indian landscape, 43% still the mortality is contributed by India. I think more and more such meetings should be held in Indian scenario, not only in severe asthma, but in asthma also, because we told that disability, limitations, and prevalence also. So even though the severe asthma constitutes only 5 to 10%, I think, I don't know how much 43% mortality in that the severe asthma contributes. So it's the right time. I must congratulate Dr. Nagarjuna for taking this initiative. I must thank my friends Raja and Salvi coming all the way to bless this meeting and share their knowledge. I am sure that more and more such activities will be conducted because Raja is a live wire for Indian Chess Society academic activities. He is a chairman of the TI committee. He has given a freedom. South Zone, you can give permission. You not bring to me. You can give permission. That's why I give permission to conduct these meetings. And we will have more and more such meetings in the future, and will raise the brand image of our pulmonology department. Thank you.
Thank you, sir, for your kind words. May I respect Dr. Pavan sir also to come on the stage, and Dr. Subhakar sir and Pavan sir to launch and unveil the severe asthma clinics at Yashoda Hospitals Somajiguda. Thank you, sir. Now moving on to the next session, that is session 3, that's on the management of severe asthma. I would like to call upon stage the chairpersons for this session, Dr. Hidayat Hussain sir, Dr. Narendra Kumar Narahari sir, Dr. V.V. Ramana Prasad sir, and Dr. S.A. Rafi sir onto the dais for chairing this session. Dr. Hidayat Hussain sir, the consultant pulmonologist, Omega Hospital, Banjara Hills. He is a professor and HOD at Shahjahan Medical College, Hyderabad, has vast experience in pulmonology and sleep medicine. Dr. Narendra Kumar is additional professor at NIMS. He did his MD Pulmonology from KMC Kurnool, senior residency from JIPMER, has over 50 publications in the field of pulmonology. Dr. Ramana Prasad sir is a senior consultant pulmonologist intensivist and sleep medicine at KIMS Hospital, has attended various national and international conferences, trained in Malaysia with Malaysian Thoracic Society. He has organized SleepCon 2015 at Hyderabad as organizing secretary. Dr. S.A. Rafi is consultant intervention pulmonologist at Care Hospital, Banjara Hills, associate professor at SIMS Hospital. He did his MBBS from Usmania Medical College and MD from Ashram Medical College. He has over 16 years experience in clinical healthcare. Just a short announcement, in view of shortage of time, we are not breaking for tea. Tea is served outside. Anybody interested can grab a cup of tea or coffee and come back and attend the session. May I now request the chairpersons to introduce the speakers for the next session.
Good morning, everyone, and the faculty and Yashoda Hospitals. For the next session, I would like to introduce the first speaker, Dr. Vishweshwaran Balasubramanian. Dr. Vishweshwaran Balasubramanian is a consultant interventional pulmonologist, Yashoda Hospitals Somajiguda. He has a DM Pulmonary Critical Care Medicine as a gold medalist from Safdarjung Hospital, New Delhi, fellowship in interventional pulmonology, Malaysia, and sleep medicine specialist. 15 publications including review articles, original research in national and international index journals, oral and personal presentations of original research in various national and international conferences. He is also a reviewer in respiratory medicine, top-rated index in National Journal Lung India, executive member, guidelines formulation and nebulization practices in India. Field of interest is interventional pulmonology, interstitial lung diseases, and thoracic oncology. I welcome Vishweshwaran.
Thank you, chairpersons, seniors, and friends. And thank you, Dr. Nagarjun sir, for initiating this session. And today I will be speaking to you about ABPA in severe asthma, how and why. So the first case of the ABPA was reported by Himson et al. So what he noticed was a case of a bronchitis, which had eosinophilia, which had bronchiectasis, with or without mucus plugs, and there was Aspergillus fumigatus in the lung. So this is how the concept of the ABPA came into existence. So what they noticed was it was more of an inflammatory disease. There was an immunological reaction against the Aspergillus fumigatus, and it was seen in most patients with obstructive airway disease of either asthma or cystic fibrosis. And later on, people noted that most of these patients had a treatment-resistant asthma, they had a transient and fleeting pulmonary opacities, and they had the structural lung damage in the form of bronchiectasis. So before we go into ABPA, the ABPA is just one of the manifestations of the Aspergillus sensitization. We have other things, what we refer to as an Aspergillus-induced asthma. This differs from the ABPA because it is just characterized by a classical type 1 IgE-mediated hypersensitivity, and it constitutes almost 16 to 38% of all the asthmatic patients whom you see. Why understanding Aspergillus-induced asthma is important is because it is associated with a severe airway obstruction, and it can be associated with bronchiectasis in few patients. But however, this does not elicit the inflammatory phenomenon what we see in ABPA, and it is a distinct entity by itself. In addition to this, apart from ABPA, we have something called as a severe asthma with a fungal sensitization. As the name suggests, you are going to have a severe asthma, which is a poorly controlled asthma, and fungal sensitization, as the name suggests, you are going to have a positive skin prick test for the fungi, or you need to have a serology test for a specific IgE. But however, the serum total IgE levels are found to be lower, which is less than 1000 kilounits per liter. And the bronchiectasis and the mucoid impactions are generally absent, and the serum precipitants to Aspergillus are negative. This is because even here you don't see the classical type 3 hypersensitivity reaction, which we see in a case of a ABPA. So this brings us to the topic proper, what is ABPA? As you can see from this picture, there is an inhalation or repeated inhalation of the fungal spores, and it causes the airway colonization in the susceptible host. This predominantly occurs in a case of a cystic fibrosis or an asthma because they have got lot of thick tenacious secretions in their airways. So there is a higher propensity for these fungal spores to get deposited in this airways, germinate, develop the hyphae, and create this immunological reaction. So it is characterized by both by the type 1 hypersensitivity reaction, by type 3, which is classical for ABPA, as well as the type 4, that is the cell-mediated reaction. But however, this ABPA is a hypersensitivity reaction, and it is not like an invasion, like an invasive aspergillosis, where you see a tissue invasion. So later on, the guidelines evolved. People started framing guidelines to diagnose ABPA. This is a classical Rosenberg pattern which is taught in almost all of the colleges, like how to diagnose a case of a ABPA. So it has got a major criteria of asthma, presence of transient pulmonary infiltrates, immediate cutaneous reactivity to Aspergillus, elevated serum total IgE, precipitant antibodies, peripheral eosinophilia, elevated serum IgE and IgG to Aspergillus, and central or proximal bronchiectasis with normal tapering of bronchi. And it had minor criteria like expectoration of golden brownish flux sputums, positive sputum culture for Aspergillus, and late Arcus type 3 reaction. But however, this had its own set of inadequacies. They didn't mention what is the level of the IgE, they didn't mention what is the level of the serum specific IgG and IgE which you need to see for a case of ABP. So then, for the ease of diagnosing ABPA, they came up with the minimal essential criteria and the true minimal criteria. So in minimal essential criteria, you've got an asthma, you've got a type 1 hypersensitivity reaction, you've got a serum total Ig greater than 1000, elevated specific IgE and IgG to demonstrate type 3, and you had a central bronchiectasis. Then people thought that it becomes more cumbersome because we need to wait for the reports of the specific Ig. So then came the truly minimal criteria, where there is only an asthma, there is an immediate cutaneous reactivity and serum total Ig and central bronchiectasis. But however, the guidelines kept evolving, and this is the latest what we have, which is produced by the ISHAM guidelines. So it is by the mycology group and the group at the PGH and they have come up with an ISHAM guidelines, which says that to be diagnosed for an ABPA, you need to have a predisposing condition like an asthma or cystic fibrosis, and the obligatory criteria must be present, that it should have an immediate hypersensitivity reaction or a specific IgE against Aspergillus, and your serum total Ig must be greater than 1000. In addition, they said that you need to have two other criteria. They brought down the cutoff of the eosinophil to more than 500 rather than more than 1000. And they said that there should be a transient pulmonary infiltrates on chest radiograph and presence of Precipitin against Aspergillus fumigatus. But however, again, this guideline was further revised. In the place of the transient pulmonary infiltrates on radiograph, the guidelines were revised to have the bronchiectasis on the CT scan, which is nothing but a sign to none of ABPA. Apart from that, they found out that few of these ABPA patients did not have the classical radiological pictures. So this led to the subtyping of the ABPA into the ABPA-S, where ABPA fits into all the serological criteria but does not have the classical radiological presentation. Then there is an entity called as an ABPA-P-B, which we called as the classical ABPA, which has got a central bronchiectasis, and an ABPA-HAM, which means that this contains the classical hyperattenuated mucus flux, which I will be dealing with it later. And in addition to this, they said that there is another entity called as an ABPA, chronic pulmonary fibrosis. So your ABPA can be seen in the setting of a chronic pulmonary fibrosis, like in the form of an aspergilloma or a fibrocavitary lesion or a pleural thickening. So apart from that, this is the latest one which has been produced by the Japanese group, which again listed 10 essential criteria which are to be there for the diagnosis of ABPA. The point of putting up all these things is, even now we do not have a 100% criteria to say that we are dealing with a case of an ABPA. So the guidelines keep evolving and new things keep coming into practice, but to date what we follow is the ISHAM guidelines, which is the most update for an Indian setting. So what is the burden of ABPA and why are we speaking in a forum like a severe asthma? Because the burden of the ABPA as per the Denning et al. Is almost a prevalence of 2.5% and there is 5 million cases worldwide. And if you take the community prevalence of ABPA, it constitutes about 5% of the cases. And if you translate this 5% of the cases to a country like India, you are going to have 1.4 million population who is going to come to you with a severe asthma. And the pooled prevalence of the Aspergillus sensitization and ABPA is around 28 to 13%. So you are going to see a lot of cases who present to you a severe asthma clinic as severe asthma, but they may turn out to be a ABPA. And if you take the overall summary of the prevalence of ABPA in the country, except for few severe asthma clinics, mostly it revolves around 5 to 7%. Whereas in severe asthma clinics, the prevalence has been quoted as high as even 22%. So this is one of the latest details we have about the incidence of ABPA in India, which was published by our own Rajada sir in the European Respiratory Journal. They said that despite the universal screening for ABPA recommended by the ERS, only 17% of our Indian patients of bronchiectasis were screened for ABPA. That means we are not screening many cases of bronchiectasis which may turn out to be ABPA. And 50% of those 17% who were screened showed an evidence of ABPA. So how are we going to diagnose the ABPA in a given setting? So you have got a patient with an asthma or a bronchiectasis, then you have to do the specific IgE first. This is something which has been against a controversial norm where we use the serum total IgE for screening of ABPA. So the current guideline says that you need to screen these patients with a specific IgE against Aspergillus, and if you have got a serum total IgE greater than 500, then you look for the peripheral eosinophil count and the IgG against Aspergillus. And depending upon your CT, you can label it as ABPA-HAM or ABPA-B or an ABPA-S. Why did we move from using a serum total IgE to a specific IgE? Because what they found that the specific IgE against Aspergillus is the most sensitive investigation for diagnosing ABPA. Because the sensitivity and the specificity range between 100 to 70% as per the study conducted in India. Whereas when you use a serum total IgE, the sensitivity is only 96%. So probably your specific IgE is preferred over the serum total IgE. But for all practical purposes, 96% sensitivity is fairly good to screen a patient with serum total IgE as well. So the ham which I was discussing to you, this is how a ham really looks like. So the important point is when you see a ham, it is a sine qua non of ABPA. So how do you diagnose ham? You need to see the Hornswell units of the ham and compare it with your paraspinal muscles. If the Hornswell units of the ham is more than the Hornswell units of the paraspinal, then it is a classical form of a ABPA ham. In addition to this, now people are moving from screening not only asthmatic patients, even patients with other disorders like COPD and post-TB. People have found out that ABPA can exist in the absence of asthma. And this is a study which said that 7% of their patients were ABPA without asthma. And bronchiectasis was most frequent and the lung function was significantly better in these patients in comparison to a patient who had got asthma. This is very important because the ABPA sans asthma appears to be a distinct subset of ABPA which has got a better lung function and fewer exacerbations, and probably you may have to phenotype this patient and put them on a lower dose of steroids in comparison to ABPA. Now moving to the staging, so we classify the ABPA based on as asymptomatic and patient who comes to you in an acute setting with either a mucoid impaction or without a mucoid impaction, and you call it as a response when you see a decline in the serum total IgE by greater than 25% at the end of 8 weeks along with a clinical and radiological improvement, and you will label a patient as exacerbation if there is an increase in the serum total IgE by at least 50% with worsening of clinical and radiological parameter. And you will call a patient with an ABPA to be in a remission when they have got a serum total IgE which is at or below 50% for greater than 6 months of treatment. And in addition to this, we have a severe forms of ABPA which is a treatment-dependent ABPA or a glucocorticoid steroid-dependent ABPA, and even an advanced ABPA which presents as chronic respiratory failure. So as a patient comes to you with an acute stage of ABPA, the first and the foremost drug what we have in the treatment of ABPA is a long-term steroid. So we give the steroid for roughly between 4 to 6 months, and in patients who are not improving, you can even escalate it to itraconazole which is given for 4 months. And you just follow up these patients with an X-ray, spirometry and serum total IgE, and you see whether the patient is fitting into a case of a response or he is going into remission or he is going into exacerbation. If a patient goes into exacerbation, you increase the dose for 4 more months, and you can combine the steroids with itraconazole. And if you feel that the patient is not getting control despite it, then probably the patient is going into a case of a treatment dependent. This is the time when the role of the experimental therapy comes into play, like use of azoles, use of long-term oral corticosteroids, and use of nebulized amphotericin B, and even biologics like omalizumab, mepolizumab or benralizumab. And the glucocorticoid dose that we start is 0.5 mg per kilogram for 4 weeks, and we sequentially taper it. And the azoles are to be used only in a case of a treatment-resistant cases where it is given as 200 mg twice daily for 6 months. And we follow up these patients at 8-week interval. And the important point to note is, even if a patient of ABPA comes to you with worsening breathlessness, it does not always mean that the patient is having an exacerbation. He can even have an exacerbation of an underlying asthma. So if you have a clinical and a radiological worsening along with greater than 50% increase in their baseline IgE levels, then only you will label it as ABPA exacerbation. If you have a patient who has got a worsening of symptoms but you do not see the radiological worsening or you do not see the serum total IgE rising, then probably you are dealing with a case of only an exacerbation of an asthma, and you need to treat these patients only with a short course of steroids like a 5 days or maximum 7 days. But if you have an ABPA exacerbation, then probably you need to increase the steroid for more than another 4 months. You may even had to add the itraconazole along with the steroids. Thank you.
One or two questions can be allowed. Does anybody want to ask a question? Again, nicely delivered lecture.
Yeah. How often you are using itraconazole for an extended period?
Sir, we had a very good experience when I was in Patel Chest Institute. So at that time, that was a Center for Allergy, and we used to have an ABPA clinic running there. So most of the cases of ABPA generally tend to subside with just steroids. the use of the itraconazole would be hardly for 5 to 10% of the ABPA cases who keep presenting with recurrent exacerbations. But apart from that, even the radiological ham, even the presence of thick mucus plugs, collapse, everything drastically improves with just steroids. So, in our experience over there, the prevalence would have been just 5 to 10% of cases where we had to put these patients on antifungals.
That's what I am telling, because most of the times after using steroids, it subsides, and we have hardly used itraconazole.
Yes. Even that, the experience has been only 5 to 10% of severe refractory cases.
Excuse me. I just want to ask one question, sir. Sir, actually, many of the times, sir, ABPA when it is diagnosed, or even HSP cases, like diabetic, if they are there, now here only the treatment is the steroids. So we are totally dependent upon the steroids. What is your alternative therapy? And for my cases, I start itraconazole simultaneously with the ABPA, and the results are fantastic because many patients are inpatients.
Yeah.
And in diabetics, it comes a very difficult part.
So definitely this is a grey zone which has never been addressed in any of the guidelines. This is what we face in the real life scenarios. So there definitely, if you feel that the patient is not able to monitor the sugar levels or not able to keep it under check, then probably decreasing the steroids and putting a concurrent itraconazole would be definitely a better option, provided the patient is not able to maintain his sugar levels. But even in diabetics with adequate sugar control, steroids would be still the first choice. But as you said, if the patient's sugars are not getting controlled, then probably you need to use itraconazole as a steroid-sparing agent. Yeah.
Steroid-sparing agent.
Yeah, it has a steroid-sparing effect also. In addition to, it has got an immunomodulatory effect also. In addition to this, it will decrease the fungal burden also. So it has got a pleiotropic effect, the itraconazole.
Any use of voriconazole in use of ABPA?
So there are few case reports. It's only anecdotal case reports and case series we have for voriconazole. People have tried, but they didn't find any extra benefit over itraconazole. So, and the initial point of contention with itraconazole was whether your lung deposition would be good with itraconazole. But people have found out that when they did the studies that lung deposition is fairly good. So, if you have an alternative, if you cannot use an itraconazole, then probably yes. But these are only anecdotal and case reports and case series.
A small question. Any recommendation of biologics like omalizumab?
Yeah.
Experience?
In experience, no. We have recruited recently one case for benralizumab because it comes under the compassionate grounds. But we don't have, because the problem is before this we had only omalizumab, and the cutoff range for omalizumab is, you say, between 30 to 700. But what we see in ABPA, the levels of Ige will be around 2,500 and 3,000. So whether it will really work is a point of contention. But people have tried even omalizumab, mepolizumab, and even in the guidelines now they say that you can even try benralizumab. So ABPA is like, again, you need to treat it like a case of an ABPA, because the ABPA-S can progress to ABPA-CB, where it becomes a permanent damage. So if you have all the criteria fitting into your ABPA, but you don't have a radiological demonstration of bronchiectasis, you will still treat it on the lines of ABPA with steroids and keep monitoring, because these patients can progress from ABPA-S to ABPA-CB as well.
Yeah, when Narendra asked this question, I thought he would share our experience. So we had this one young boy who had ABPA referred to us because of the lung nodules. They said these are some lung nodules, and then finally we thought it is ABPA. And important thing is it ABPA that is causing the problem, or is asthma that is causing the problem? And in a young patient, we were worried that we cannot go to very high doses of steroids in this patient. So we gave him omalizumab, and he put so very well, and then now he's a very grown up boy. So that's the experience with
that is that. Even in the guidelines they have specifically addressed that. If you have a clinical worsening without radiological worsening or increase in the serum total Ig, we would still treat it as a case of a severe asthma. Only when you have concurrent worsening in the radiological aspect or concurrent worsening in your serum total Ig values, let's say it doubles, and it's fitting into your clinical criteria, then probably we are dealing with a case of an exacerbation of ABPA.
So we have to learn a lot of things from our rheumatology colleagues, where we have to be very conscious of these steroid side effects.
And once we had
when you have an option of a drug that can be steroid sparing, like biologics, I think we have to make use of biologics much earlier. than increasing the dose of steroids and getting into complications. We had one lady who came up with sepsis multi-organ failure because we continued to give steroids and itraconazole, and there is a combination of itraconazole, steroids, side effects, and then steroids get together. So we have to be very conscious of that. Yeah.
And just to share, we had one very interesting case where the patient started with an ABPA, ended up having an invasive aspergillosis. That is also reported. So we need, as Paramjyoti sir said, we need to have a very high threshold on looking for the side effects of the steroids.
Thank you, Mr. Sir. I'll just make a small interruption. We're running 45 minutes late, so I request the speakers to stick to the time, and we'll just take one question, because all of these case scenarios we also have in the case presentations in the afternoon, so where we can have the experts' opinion from the international and the national faculty. We'll just limit to one question so that we'll stick to the time. Thank you. Okay. For the next talk, I would like to invite Dr. Vijay Kumar Chenamchetti. He is a senior international pulmonologist and sleep disorder specialist, Apollo Health City. He did his post-graduation from the AMC Vizag and his observership in lung transplantation at the University of Texas. He is a member of various organizations and he has presented research work at various national international conferences and also a very good speaker at various national conferences. I welcome Dr. Vijay.
Thank you, Narendra. Can I have my slides, please? At the outset, I congratulate Team Yashoda for doing this versatile program. And thank you, Nagarjuna, for having me here. So, slide. So in the next 14-15 minutes, we will be, the goals of the talk will be, what are the unmet needs of the existing bronchodilation therapy in the severe asthma, and pathophysiology of asthma, definitions of uncontrolled versus difficult or difficult to treat asthma and severe asthma. What is the current placement of Llama and Ultra-Llama in today's practice? Is triple therapy a game changer in bronchodilation? What is the role of single inhalation triple therapy in severe asthma? Nebulized bronchodilators in Indian context? And what does both patient and pulmonologist expect from the inhalation therapy, and take-home bullets? So, the current unmet needs of ICS and LABA include, the current existing LABAs, they are less selective beta-2 receptor action. With that, they are less potent and they also have greater off-target effects. LABA has, except for formoterol, it has got slower onset of action, thereby delayed symptom relief. On the other hand, inhaled corticosteroids, which are available currently, they have got high oral bioavailability, thereby chance of having a systemic exposure and then side effects. And current recommendation of twice daily ICS plus LABA combination may be a cause of reduced compliance in the current population, and probably if we can reduce it to once daily dose, we can increase the adherence. So looking at the pathogenesis, we have discussed, but to be short, once the allergen is entered, the two kinds of pathways that are triggered here, that is both TH1 and TH2 pathways. There may be, we must remember that in some group of patients there may be both TH1 and TH2 may be active, and we may need to target on both the pathways. And once the TH2 is stimulated, IL-9, IL-13, IL-4, IL-3 and IL-5 gets activated, resulting in activation of basophils, eosinophils and mast cells, and further culminating in the hyperreactive airway disease, inflammation and mucus hypersecretion and airway remodeling. Whereas on the other hand, the TH1 stimulation, the inflammatory mediators exist here are interferon gamma, IL-2 and IL-4, and through macrophage activation, and finally the cell-mediated immunity and neutrophilic inflammation predominates in this pathway. So glucocorticoids exhibit the inhibitory effect at various Th2 pathways, whereas the final common pathway where the muscle relaxation occurs through beta-adrenergic agonists and muscarinic antagonists occurs is in beta-adrenergic LABAs. The increased CAMP level leads to smooth muscle relaxation, and whereas through M3 receptors, LAMAs cause bronchodilation. And the definition we have discussed here by previous speakers: uncontrolled asthma as defined by poor symptom control and frequent exacerbators as defined by at least greater than 2 per year, which requires the oral corticosteroids, or serious exacerbations at least greater than 1 per year, which requires hospitalization. And difficult to treat asthma, please remember, it does not mean that all the cases of, it does not mean that it's a difficult patient. In many cases, asthma may appear to be difficult to treat because of other modifying factors, like there may be poor inhaler techniques and poor adherence, and smoking may be an additional feature. Coming to severe asthma, what proportion of our adults have severe asthma? This is a wonderful publication which was from Netherlands in 2015. Almost 24% of patients in adults, they are receiving high intensity treatment. By definition, high dose inhaled corticosteroids plus LABA, or medium dose inhaled corticosteroids plus LABA plus oral corticosteroids, and 17% are difficult to treat asthma, where they are on high intensity treatment, but despite on high intensity treatment, they have poor symptom control, and approximately 3.7% are having severe asthma, where they are on high intensity treatment, and they despite on high intensity treatment, they have poor symptom control, but the adherence to the inhalation therapy is pretty good. And the current choice is smart therapy, both as a maintenance and reliever therapy, which we know pretty much. What are the various bronchodilators available in our practice? Inhaled corticosteroids include beclomethasone, budesonide, fluticasone, mometasone, beta agonists, SABA, salbutamol, levosalbutamol, and terbutaline, and LABAs, formoterol and ultra-LABAs, indacaterol and bilanterol. The conventional muscarinic agonists are tiotropium, whereas ultra-LAMA is glycopyrronium and umeclidinium. And here there are various other molecules which are available in the current studies. So this looks like that in the coming future we have very good amount of bronchodilators available in LABA and LAMA group, so that they may have very promising bronchodilation for our patients. And yes, we all know that advantages of inhalation therapy is lesser systemic toxicity, more rapid onset of action of the drug, since the drug is directly delivering to the target site. The current ultra-LABAs which are available in India are indacaterol and bilanterol. Indacaterol exhibits, in addition to bronchodilation and ultra-long acting, anti-inflammatory and anti-tumor effects as well. Iridium study, it's a once daily, it's a randomized double-blinded control phase 3 study, where once daily single inhaler mometasone, indacaterol and glycopyrronium versus mometasone, indacaterol, or twice daily fluticasone, salmeterol in patients with inadequately controlled asthma. The primary objectives which were analyzed here are trough values of FE1 at 26 weeks. Secondary objective is ACQ 7% at 26 weeks, and other objectives were also assessed. They were usage of rescue medications, number of asthma exacerbations, and comparisons with the high dose salmeterol and fluticasone. I'll go through the results of the study in a couple of minutes. And coming to organ study, which is a randomized phase 3B non-inferior study where fixed dose combination of indacaterol, glycopyridine, mometasone, furoate once daily versus salmeterol, fluticasone twice daily plus in an additional inhaler tiotropium once daily in patients with uncontrolled asthma was studied. In this study, trough FEV1 change from baseline at week 24 was assessed. In terms of lung function, the triple combination in single inhaler therapy improved the FEV1 versus salmeterol and fluticasone high dose plus Tiovo at 24 weeks. And the conclusion is high dose triple combination in a single inhaler therapy was effective in improving the lung function as early as 8 weeks, whereas medium dose triple combination in comparison with conventional doesn't reveal any significant improvement. So what are the various studies that are available on Vilantrol? Vilantrol, the ultra LABA, if we look at the various studies that are available, the Vilantrol plus was compared with Vilantrol, fluticasone was compared with salmeterol and fluticasone, and the study, the conclusions are there is no difference between the two arms, where the key parameters they assessed were trough FEV1 levels, rescue usage of SABA, ACT score, exacerbations, and adverse events. What is the role of Llama? So, Llama may be considered as an add-on therapy to persistently uncontrolled despite medium to high dose ICS and LABA. It can modestly improve lung function, but evidence says there are no difference in symptoms. It can modestly reduce the exacerbations as well. But remember, when we are prescribing in less than 18 groups, we have to prescribe the Llama as an additional inhaler, and the molecule of choice is tiotropium, because umeclidinium and glycopyridinium is not approved in less than 18 years. And if there is no evidence of any type 2 inflammation, we can consider Llama as an add-on therapy before venturing into biological management. Do not treat LABA or Llama alone without the presence of inhaled corticosteroids. This is very, very important. So, GINA approved triple therapy. Various combinations are available like Trimbo, Anazair and Trelegy. Whereas in India, what are the various combinations that are available? So, the first combination is fluticasone, glycopyrrolate and formoterol. It is available as AZFR through Glenmark. Whereas the second combination is budesonide, glycopyrrolate and formoterol, and it is available as glycohel FB rotacaps. And coming to the triple inhalation therapy, where it is a systematic review and meta-analysis that was published recently in JAMA, but the question is there any addition of, by adding Llama, so to inhale corticosteroids and LABA, is there any differences in clinical outcomes and adverse events? And this meta-analysis reviewed almost 20 randomized control trials. Almost 12,000 patients were analyzed, and this revealed a significant association with the triple therapy has, the arms which contain triple therapy has resulted in fewer severe asthma exacerbations and slightly better asthma control. But remember, there is no significant difference in the quality of life or most adverse events. So, looking at this forest plot analysis, which did reveal that in panel A and panel B, the forest plot analysis favors the triple therapy to decrease the rate of exacerbations, whereas the Kaplan-Meier failure curves shows that addition of Llama to ICS and LABA, definitely it is going to decrease the time to first exacerbation. So, is this single inhaler triple therapy is safe enough to practice? This is a study that was from Japan, which they analyzed in almost 100 and odd patients, and they revealed that there is no new safety concerns related to single inhalational triple therapy. Another meta-analysis, and the summary of this meta-analysis, the Iridium study, Argon study and Captain study. These are the key studies where all are phase 3 single inhaler triple therapy randomized controlled trials. They were compared with LABA and ICS in patients with poorly controlled asthma. So all of them has revealed there is definitely reduction in moderate to severe exacerbation when single inhaler triple therapy was versus in ICS and LABA, conventional ICS and LABA. Only group, if we look at the Argon trial, where the medium dose of triple therapy versus the salmeterol fluticasone in addition to Tioga, there is slight increase in the exacerbation rate. This can be combated with high dose mometasone in the triple therapy with a single inhaler trial. And in Captain study, there is no statistical significance between the two arms. So what is the role of nebulizations? Large dose of drug can be given. It can be used with relaxed tidal breathing. It is suitable in very young patients and very old patients and acutely ill patients as well. Many drug combinations, drug solutions can be aerosolized, whereas the disadvantages include bulky, cumbersome and expensive, wasted drug in the nebulized reservoir, and variation of aerosol delivery depending on the moderate to severe exacerbation. It consumes time, it needs a power source or battery operation, and regular cleaning and hygienic maintenance of the equipment is mandatory. So what are the various formulations that are available in India? Glycopyrronium is available as respules through various companies, Glycohale, Nepsmart-G and Is. Whereas LABA plus ICS is available as Foracort, Budamate and Nepsmart-FB. And LABA-LAMA combinations, LABA-LAMA and ICS combinations and ultra-LABAs are not available so far. So what are the various patient and pulmonologist side perspectives? If you look, patients can be better adherence and compliance with single inhaler triple therapy when compared to different inhalers. And from pulmonologist perspective, it is very easy and convenient for pulmonologists or physicians to prescribe once daily dose regimens, thereby minimizing number and frequency of inhalers. Monitoring technique of inhalation is very, very easy. And as we discussed, there may be role of addition of LAMA in different various endotypes as well. And when we compared or in the Western market, the cost beneficial is not too great because using a conventional LABA plus ICS plus additional tiotropium is far cheaper than compared to the single inhaler triple therapy. And way forward, it is really time to make triple therapy available in various devices with the different dosage flexibility of the corticosteroids. Coming to take-home messages, conventional dual inhalation therapy has its own limitations. Ultra-LABA carries anti-inflammatory and anti-tumor effects besides rapid bronchodilation. Single inhaler triple therapy can benefit various phenotypes and endotypes. Before attempting to add oral corticosteroids, single inhaler triple therapy can be attempted to decrease overall systemic adverse events. Are we going to pre-smart era? That means before the advent of single maintenance and single maintenance and reliever therapy, so we are again going back to pre-smart era, where along with single inhaler triple therapy, we may need to add a reliever medication as well. And what is the perfect reliever medication? Is it SABA or is it SABA plus inhaled corticosteroid? That's a $1 million question. There's a lot of literature has to evolve. Triple therapy is definitely superior to conventional dual therapy as per Iridium study. Single inhaler triple therapy is non-inferior to conventional ICS plus LABA and additional LAMA as per Argonne study. Once daily fluticasone plus vilanterol is non-inferior to conventional twice daily salmeterol and fluticasone. As ultra-LAMAs are not yet approved in less than 18 years, consider use of tiotropium with additional inhaler when the age group we are dealing is between 6 and 18. And fluticasone, glycopyrronium and formoterol and budesonide, glycopyrronium and formoterol are currently available in India as single inhaler triple therapy. And the overall pooled analysis revealed triple therapy favors decrease in exacerbations, moderate improvement in SCQ. There is no significant improvement in quality of life. High dose triple therapy favors lesser exacerbation in subset of patients with type 2 inflammation. This is as per Captain study. Way forward, it is really time to develop the triple therapy available in various devices with various dosage flexibility. Evidence favors beneficial effects of single inhaler triple therapy in both patient and pulmonologist prospects. Thank you.
Well delivered, lecturer. Only one question can be taken. One question.
Sir, what is your experience about the high doses of LABA? When formoterol came, it was a wonder molecule, we say. So what about the side effect of LABA, sir, inhaled LABA, mainly formoterol, which we are talking about, and the single drug, as we are telling, in all the doses, formoterol is kept at 12 this thing,
yes.
12 only. So what about, I mean to say, what is the side effect of this thing, sir?
So definitely at a higher dose, it may not be cardioprotective. There is a chance of having arrhythmias.
And any other compliance of the patients, sir? So many of the patients, if you give for 1 or 2 months also, they say excessive cramps. They won't tolerate it, sir. Generalized weakness. So if you give it 6 microgram BD, it's excellent acceptability is there. So in all SITT, there is a high dosage.
Yes.
So as you said, the flexibility and dosage modification definitely it requires in future, depending upon the compliance of the patient. This is my personal thing, sir.
Agree.
Yeah, that is the main drawback of this triple therapy.
We are moving to the smart therapy. So maximum inhalation, the recommended is up to 3. If you are going beyond 3, definitely, because this formoterol dosage is going high, we are recommending SOS you can take. But patient if doesn't feel relieved, he will go on taking. ICS we are building up, no problem, but formoterol is also going high. This definitely gives the cramps, tachycardia, what else, all cardiac toxicity. So it should be minimized to 3 to 4 puffs. You cannot take as if whatever is the dose he wants. If still not responding, better to come to the ER rooms.
So long-term nebulization, sir, regarding that also we do. Long-term nebulization.
Long-term nebulization, we don't have triple combinations. We have only 2. Okay.
LABA is there, sir.
Yeah, LABA is there. So even that also 3 to 4 times maximum. If it is going means definitely cardiac toxicity will increase.
And most of our patients will be definitely having all other comorbids as well.
The maximum dose of formoterol recommended as per GINA in the smart approach is up to 72 micrograms. So you can give up to 72 in reality, but most patients would not go to that level because of the side effects. Mostly we restrict to maybe 6 to 8 plus maximum. And then most of the times it's even when the symptoms are increasing, it's for a short duration of time. So maybe for
so in the nebulization already we are getting 25, 50 we are getting, sir. So how long? I think one month, 25 is there, sir. Yeah.
I think up to 72 micrograms, that is for the Western population.
So that's why in real world we do not...
No, we will be increasing our cardiologist referrals.
No. What we have come across is people come back to us telling that a lot of tremors and tachycardia is there, palpitations is there. So invariably we have to discontinue or stop or increase the dose of steroids. So I think it's a very common experience amongst our patients.
Thank you very much, Dr. Vijay. Next speaker is Dr. Deepak Talwar. Director, Chair, Pulmonary, Sleep, Critical Care Medicine, Methodist of Health Sciences, Fellow American College of Chest Physicians and National College of Chest Physicians, Fellow Indian Sleep Disorders Association, and is the Senior DNB teacher since 2008, and more than 48 national and international papers, including in NEJM, BMJ, Chest and Respirology. And it is my pleasure to welcome Dr. Deepak Talwar.
Due to a last minute change, Sir is unable to be here physically. He recorded a talk and sent it over. Sir will be there live in the next session where we can discuss and ask any further questions.
Thank you, Yashoda, for inviting me today. And also, I would like to congratulate Nagarjuna to start the severe asthma clinic. I'm going to talk about how I phenotype severe asthma case in an Indian scenario. As the word itself means that Indian scenario is a little different, and it is primarily because of a lot of reasons in using precision medicine in the management of severe asthma, the prime being the cost. We start with, a lot of work to do, and simple phenotyping is not one step, but in fact it has a number of steps which are required, and each step has got a checkpoint which needs to be considered. So we start from the bottom of this pyramid by confirming the severe asthma, and I'm sure that you have already heard earlier speakers to talk about the difficult to treat asthma before you reach the diagnosis of severe asthma. Then you look for the identification of targetable and treatable traits in the patient. That what do we need to actually target it? Because the reason to phenotype is to offer them precision medicine. And we have a precision medicine in the form of biologics, and hence we see that what are the endpoints in the biologics which are targetable and treatable, and are they there in the patient or not? And if they are there, we would like to see that and match them and keep them as our priorities. Then we endotype them to look for that they are basically type 2 inflammatory asthma, which has this biologics working against them. And in that category, we move on to find out whether it is IgE driven, is it eosinophilic or IL-5 driven, or is it driven by IL-4 or IL-13, against which the drug is yet not available to us. So primary objective in India in phenotyping is to find out whether our severe asthma is type 2, and if it is type 2, it is driven predominantly by IgE or predominantly by IL-5. And then we look for the eligibility criteria of these two group of biologics where the patient would fit in. And finally, before we go on and start the therapies in these patients, we try to have a shared decision making where we discuss with the patient about the predictors of response on the basis of which we are going to choose, particularly in the overlap group, set their timelines and fix that what would be the mutually acceptable results to say that the drug is effective, and we would like to continue beyond that timeline of initial response assessments. So this is, as I said, that not one step, it requires multiple checkpoints, and the first checkpoint is that are we really dealing with severe asthma? And I'm not going to go into this slide, but it only tells us that there are multiple steps required, which you have already learned. Confirm the diagnosis, look for compliance and inhaler technique, eliminate the exposures, treat and diagnose comorbidities, and look for all other options which are non-biologics, which we have used except oral corticosteroids. Give them some time to these patients to get into all these steps being amalgamated in their treatment regimen, and to see whether the response comes or they are still severe asthma requiring biologics. Second checkpoint, as I said, is what are those targetable traits which we need to look into it, so that we have the right reason to use this precision medicine of using biologics in the patients. So at the various checkpoints, this checkpoint is very important because it is trying to look at it, what to expect in an individual patient. Do we expect to reduce exacerbations, reduce hospitalizations, eliminate the use of oral corticosteroid maintenance dosages, improve the quality of life, or improve the lung functions? By and large, all of them have been shown to be improved in patients on biologics in type 2 inflammation, and we have to individualize the predefined targets for the patient. Every patient doesn't come with exacerbations or hospitalizations. There are patients who will maintain on oral corticosteroids, and there are many patients who will treat exacerbations at home by using repeated bursts of oral corticosteroids. Some of the patients have got very poor quality of life, and there are some of them have got very severely impaired lung functions. So we define that our goal of treatment or control of asthma in this individual patient on whom we are going to phenotype, we will be targeting 1, 2, 3, 4. How much improvement is expected in them, and we define generally or predefine the cutoffs for these patients. This third checkpoint which is there is that is it type 2 inflammation, because at present we have only biologics or precision medicine available for type 2 inflammation, also called as type 2 high or predominantly an allergic or eosinophilic type of inflammation. So for this we initially use the clinical markers like age of onset, early childhood onset or early adulthood onset is more likely to be IgE mediated. Late adulthood or late onset asthma has more likely to be eosinophilic. Then we look at the allergic comorbidities like atopic dermatitis or severe allergic rhinitis as again indicative of IgE mediated driven disease, while nasal polyposis, chronic sinusitis and EGA are more likely to be associated driven by eosinophils. ABPA is driven by generally both of them. And then very importantly, type 2 inflammation is the one which is oral corticosteroid responsive. So these patients, whenever they are given oral corticosteroid, they feel better, and whenever you switch them off or decrease the dose, their symptoms in the asthma control goes out of hand again. So this kind of cases are considered as the cases for biologics and need further endotyping, but this kind of endotyping will require some amount of biomarkers. Uma has already dealt with the biomarkers. We have serum periosteum and blood and sputum eosinophils as the three most important biomarkers. We also use IgE and specific IgEs or strain pit test and exhaled breath nitric oxide, but they are more relevant in certain situations rather than across all kinds of type 2 inflammatory severe asthma. So we define a type 2 inflammation in a patient of severe asthma who's on high dose inhaled corticosteroids but with long-acting beta-2 agonists who show that their blood eosinophils are more than or equal to 300 or pheno more than or equal to 20. Sputum eosinophils we don't use, so in our phenotyping we use either blood eosinophils or exhaled breath nitric oxide as a biomarker to identify type 2 inflammation along with the clinical criteria. As I said that IgE total, IgE specific to aeroallergens as well as skin prick test to aeroallergens are the other parts which we look for it, which helps us to decide upon the choice of biologic or giving an idea of what is driving the inflammation in an individual patient to us also. Moving on to with these patients further, we have to look for one most important biomarker which is blood eosinophil, and in Indian scenario this is very, very important, realizing that we know OCS and high dose ICS do interfere with the levels of blood eosinophils, and we also have an idea that perhaps our patients might have higher blood eosinophils than the Western population because of the various reasons. So we check the blood eosinophils not at one time but at multiple points. Try to do it whenever they are at the lowest possible dose of OCS, and sometimes when they are not able to decrease the dose of OCS completely or eliminate their use completely, we try to just decrease the dose and see whether the eosinophils do rebound in the blood or not. Blood eosinophil is the most important biomarker which we use in phenotyping in Indian patients with severe asthma. We try to scan all their previous reports and charts to look for all eosinophil counts available in the last 1 year or even before that, and try to correlate it with the oral corticosteroid dose which is being given. Generally, we take about 300 value of eosinophil in all our patients, but sometimes it may not be there on the day of visit, and if it is above 150, we try to scan the previous reports and consider the clinical criteria whether they are qualifying for the type 2 inflammation in severe asthma, and also sometimes the pheno value also. Once we have done this, we move on to the next point, which is to find out whether it is IgE driven or it is eosinophilic driven. And I've already told you the most important clinical aspects are the age of onset and whether there is history of allergen exposure causing the symptoms or not, and associated comorbidities along with the other symptoms of the patient. Skin prick test and specific and total IgE are primarily used for IgE-mediated severe asthma, while eosinophils in the blood is the most common one, with the pheno which we use for the eosinophilic asthma, but mostly pheno is IL-13 driven. So we particularly, when we look for eosinophilic, that is IL-5, we go for the blood eosinophils. However, both the types of this type 2 inflammatory severe asthma patients, they are oral corticosteroid responsive. On the basis of this, when we look back into our data of phenotypes in asthma, severe asthma, using clinical and biomarkers, we find that out of 100 severe asthma patients, we find eosinophilic in 49 and type 2 low in 15. And atopic asthma, purely atopic asthma or IgE mediated or what we call as allergic asthma in 36% of patients. But very peculiarly we found that almost 30% of patients do depict the features of atopic asthma, that is IgE driven, allergic asthma as well as eosinophilic asthma. So 30% of phenoendotyping of severe asthma in Indian scenario to us reveal that these are the overlap group. And they will be eligible for both the biologics, and we need to be very careful how to choose it. This overlap phenotype has been reported worldwide. It accounts for 30 to 50%, and these are the patients in which we need to choose either anti-IgE or anti-IL-5, and generally the decision is taken when the IgE levels are very high beyond the 1500, which is not an eligibility criteria for omalizumab. We need to tilt the balance towards the anti-IL-5. Similarly, if there are very high eosinophils, again the balance is tilted towards the anti-IL-5 drugs. Concomitant nasal polyposis again pushes us to choose anti-IL-5, while atopic dermatitis or allergic rhinitis pushes us towards choosing the omalizumab. But once the biologic decision is taken, it is not over. And this kind of decisions need to be taken case by case, and failure of one therapy may lead to switch of the therapy to the other type of biologics. When we look at the eligibility criteria and the indications of the three biologics available in India, omalizumab, mepolizumab and benralizumab, in India the most important criteria is that we may not be able to use omalizumab if the IgE is more than 1500 or a body weight is more than 150 kg. Similarly, the eosinophil count is mostly required more than or equal to 300, but mepolizumab is also eligible to the patients who have eosinophilic asthma and have eosinophil count on the day one of the visit, which is more than or equal to 150. So if you see that there is a little overlap as well as little different criteria being used to use two anti-IL-5 drugs. But by and large, they are all indicated in moderate to severe genus step 5 patients who have type 2 inflammation. And IgE mediated, we have used it for children also, but as far as Mepo and Benrali is concerned, at the moment we have only used it in adult population. So when we look for all this data of our patients for the eligibility of biologics, we found that more than 90% of patients are actually eligible for biologics, and 15 patients who were initially classified as type 2 low asthma actually had the eosinophil count of more than 150 on the day one visit, which again makes them qualified for mepolizumab. So you can see there is considerable overlap between omalizumab, mepolizumab, benralizumab as to the eligibility criteria depending upon the on-label indications as being given on that. So the primary responsibility lies in the overlap group, which is almost about 50%, which are eligible for both the biologics, lies in finding out that what is the more likely driver for inflammation in an individual patient, IgE or eosinophil. And many a times when we are really confused, we go by the other factors which I have already discussed, which are clinical, as well as the blood investigations and biomarkers, which help us to choose one over the other in such kind of patients. The last point is that when we are really confused which one to choose and it doesn't give a clear flavor of IgE versus eosinophil, we try to look for it that are the predictors for good response for IgE mediated targeting by omalizumab, or it is for the anti-IL-5 targeted IL-5 targeted therapies. So predictors for good response to look for in these patients particularly we see is the childhood onset with allergy driven symptoms, as well as for anti-IL-5 we look for adult onset and associated nasal polyposis in our scenarios. So the care pathway for patients of severe asthma, type 2 inflammation who are being chosen for biologics is like this, which is a little different. We straight away look for whether this patient is IgE driven, allergic symptoms driven by IgE, then we choose omalizumab. But if not, we look for eosinophils, and if the eosinophil criteria is qualified, we go for anti-IL-5 drugs. But then considering that there are a lot of patients who have high eosinophils as well as they fit into the criteria of having some symptoms being driven by IgE, so-called as overlap, we would not like to use one and move to other. We would like to add on to the other features to distinguish this overlap group into the one which is more likely to respond to omalizumab versus the one which is more likely to respond to anti-IL-5 drugs. So IL-5 features once again young, allergic rhinitis, allergic dermatitis, urticaria, and very strongly positive atopy test or specific IgE to aeroallergens, which are perennial aeroallergens. On the other hand, the predictors of good response for eosinophils is older age, IgE very high, OCS use on maintenance dose or associated with nasal polyposis. And once we start the therapy, we observe these patients for the effectiveness. If they are effective, we continue. Otherwise, we consider the causes of failure and whether we can switch or not. And lastly, what I said is that once everything has been done in the phenotyping, the final step is to start it. And at the time to start, we have a shared decision making with the patient where we set the goals. And these goals are set as per the clinical trial results. If you expect the exacerbations, about 50% reduction, OCS dose 50% to 100% reduction, improvement in asthma control and lung functions, as well as quality of life of these patients. We set the goals and time frame equally important for us, and the time frame is generally kept at 4 to 6 months. We tell the patients that we are going to reevaluate you at 4 months with our pre-defined targets as well as the goals to be achieved in 4 to 6 months. If they are doing good, we continue the therapy. Otherwise, we discuss whether it's a partial response or no response and then take the actions accordingly. With that, we come to the end where again I bring the same pyramid which shows that in Indian scenario, there are 3 things most important to consider. Identify the targetable traits for an individual patient with type 2 severe asthma, and then look for it whether it is allergic or atopic IgE driven or eosinophilic driven. And finally, some of them who seems to be not candidates for either of them may be eligible also to mepolizumab, where the eosinophil counts may not be required about 300 as it is on the first visit. And then of course we need to, because of the overlap group in India being very common, match the predictors of response with the targetable goals of the biologicals in the individual patient. So the most important step, I think, the phenotyping which it leads to ultimately is the shared decision making. And it must be mutually acceptable, otherwise it would lead to a lot of non-compliance to this therapy, which is the most important therapy to alleviate the patients of severe asthma from the suffering of the disease as well as getting the asthma control back without using oral corticosteroids. Thank you again. Thank you again everyone for listening to me, and thank you organizers for having me.
That was a wonderful lecture by Deepak Talwar sir. I think we missed his flamboyant presence here, but I think on that note, I think our senior faculty here, Sandeep Salvi sir or Rajadhar can take maybe 1 or 2 questions and certainly have.
I think you can have questions in the right cases. So we have a lot of cases similar.
Okay, wonderful session. To close it, thanks Dr. Nagarjuna and the Yashoda team.
Thank you to the speakers. May I request Dr. Sandeep Salvi sir to come onto the stage to give mementos to the speakers and the chairpersons. Dr. Vijay Kumar sir. Vishweshwaran sir. Dr. Hidayat Hussain sir. Dr. Ramana Prasad sir. Dr. Narendra Kumar sir. And Dr. S.A. Rafi sir. Now we move on to our next session. We will be discussing about the biologics currently available in India for the treatment of severe asthma. I would like to welcome on dais Dr. Alimuddin Naveed sir, Dr. Lakshman Babu sir, and Dr. Vishwanath Gella sir to chair this session. Dr. Alimuddin sir is a professor in Department of Pulmonary Medicine at OAC Hospital, Hyderabad. He is consultant pulmonary at Esra Hospital, Hyderabad, and he has more than 20 years of experience in the field of pulmonology. Dr. Lakshman Babu sir is consultant intervention pulmonology and sleep medicine at Sunshine Hospital, Secunderabad. He has trained rigid bronchoscopy from Marseille in France, trained in EBUS and cryotherapy from Gangaram Hospital, has over 13 years of clinical experience. Dr. Vishwanath Gella is a senior intervention pulmonology consultant at AIG Hospital, was the first to introduce EBUS in the Telugu states, and has various number of international and national publications. May I request the chairpersons to introduce the speakers for the next session.
Good morning, everybody. Our first speaker is Dr. S. Balamurugan, who is a professor and HOD of Department of Pulmonology in Sri Muthukumaran Medical College. He specializes in pulmonology, critical care and sleep medicine, fellow of College of Chest Physicians from USA, and fellowship in pulmonology, critical care and sleep medicine from Madras Medical College, Chennai. He is a member of IMA, ICS and ERS. Over to you, sir.
Thank you, sir. Good afternoon all. I am Dr. Balamurugan from Chennai. Nice to be in this part of the world, in warm greetings from Chennai. I sincerely thank Dr. Nagarjuna for inviting me, but he has given me a tough job of sticking to the time, which I always feel uncomfortable right from my UG days. Right. It's easy and tough to talk in the later phase of the day. Easy in that sense, most of my previous speakers, especially Dr. Deepak Talwar, has made my job easier. But at the same point of time, we will have to live up to their expectations. No, it's not on this.
I think there's one more pointer which looks on this one.
Alright, this is going to be my agenda of today's talk. I think most of the slides are just to brush what we have learned since today morning. We'll talk initial aspects of what is severe asthma.
Okay, so we'll talk about the basics of asthma, just brush through the slides. We'll talk with special reference to omalizumab, what is the molecule, what is the mechanism of action, how do we select a patient, whom to give omalizumab, and we try to talk about the real world experiences. Both I would take one clinical trial in the Indian context as well as the international context. Yes. Okay. This has been already talked by the previous speaker. Steps for investigating and treating severe asthma. We'll talk about omalizumab, how to select patients for the molecule, and what is the real world evidence towards that. Okay. Definition of asthma keeps on changing. The emerging definition is this. So this is characterized by chronic airflow inflammation, airway inflammation, and airway remodeling, which was formerly considered as a single disease. And with the introduction of the concept of asthma syndrome, the various key clinical characteristics of it were confined under the broad umbrella term of bronchial asthma, which includes features of asthma severity, like the lung function, symptoms and exacerbations, and patients with both allergic, that means the Th2 high, and non-allergic, or the Th2 low inflammation. And there has been a definite shift in the paradigm of asthma from a single disease towards a complex and chronic disease with marked clinical heterogeneity. Right. So how do we define severe asthma? This is nothing but the disease which requires treatment with guideline-suggested medications for genus steps 4 to 5 asthma, that we give high-dose ICS and LABA or a leukotriene modifier with or without theophylline for the previous year, or systemic corticosteroid usage for more than 50% of the previous year to prevent it from becoming uncontrolled, or which remains uncontrolled despite this therapy. Or for practical purposes, we can consider severe asthma as therapy-resistant asthma. We all know uncontrolled asthma, nothing but poor symptom control by frequent symptoms or frequent use of reliever medication like SABA. The activity is limited by asthma, nocturnal awakening because of bronchial asthma symptoms, and associated with frequent exacerbations, that is more than or equivalent to 2 exacerbations a year, that requiring oral corticosteroid usage, or serious exacerbations more than 1 per year which requires hospitalization. And then we have the difficult to treat asthma, which is nothing but uncontrolled despite step 4 or 5 treatment, or which requires such treatment to maintain good symptom control and reduce the risk of exacerbations. And then we have the severe asthma, that is nothing but uncontrolled despite adherence. That is a key difference between this and this. Here we need to check the adherence to the medications, the inhaler technique usage. So the patients are properly and religiously using the medications what you're giving them, and also following strict guidelines apart from proper inhaler technique. In spite of that, if they continue to have the symptoms, probably these patients can be branded as having severe asthma. Okay. We talk about the clinical phenotypes, basically 2 types. One, we have the inflammatory phenotype, and then we do have clinical phenotype. For example, the clinical phenotypes can be further divided into 3 things, where the patients with asthma, frequent severe exacerbations, please do understand this group of patients, in between the exacerbations, they might lead a normal life. And the other hand, we have a fixed airflow obstruction, and then we have the corticosteroid dependent asthmatics. This has been dealt pretty nicely by various speakers since morning. So I am not going to detail of this particular slide. So what are the common problems that need to be excluded before a diagnosis of severe asthma can be made? One is the poor inhaler technique. This is the most common thing what we face in our part of the world, that there up to 80% of the PrEP patients. Poor medication adherence. For example, you could be prescribing formoterol budesonide twice a day, but the patients intentionally or unintentionally take once a day or every alternate days. Incorrect diagnosis of asthma with symptoms due to alternative conditions like laryngeal obstruction, cardiac failure, lack of fitness, etc. Various comorbidities and complicating conditions like rhinosinusitis, gastroesophageal reflux disease, obesity, as well as obstructive sleep apneas, and lots of ongoing exposure to sensitizing or irritant agents either at home or at work. Right. We'll talk about the key 7 steps for investigating and managing patients with difficult to treat asthma. The first thing is obviously to confirm the diagnosis, whether it is really asthma or anything else which mimics asthma. Second thing is to look for factors that contribute to various symptoms, exacerbations, and poor quality of life of our asthmatics. Third thing is to optimize the treatment. Review, I would say every 3 to 6 months. If asthma is still uncontrolled, a diagnosis of severe asthma should be made. And the fifth thing is to assess the severe asthma phenotype and also assess the type of inflammation, whether it is T2 or non-T2 type. So as per the type of inflammation, consider non-biological treatment or biological treatment. We'll talk about that in the later slides. Review the response. I think review response should be key. I would put it in my practice as every once in 3 to 6 months. And then the 7th step to continue, optimize the management on a frequent basis depending upon your response to the treatment. I think I will not talk in detail about the first 4. We'll start from here, the 5th one onwards. So assessing the severe asthma phenotype and the factors contributing to the symptoms, quality of life and the exacerbations. So if we have to diagnose a case of asthma, first and foremost thing is to assess the severe asthma phenotype during high-dose inhaled corticosteroid treatment or the lowest possible oral corticosteroid dose. Check their blood eosinophil counts, the pheno, and if the asthma is clinically allergen-driven, that is based on other parameters like, for example, rhinosinusitis, etc. Need for maintenance of oral corticosteroids. Investigate for various other comorbidities as we're talking about the GERD, etc. Differential diagnosis and treat. If it is not possible, try to refer the patient to severe asthma clinic. Consider various investigations like, for example, a complete workup of the Ig levels, the fungal precipitants, a HRCT chest, etc. Other directed testing based on the clinical suspicion, and also consider the need for social and psychological support. So involve as much as possible a multidisciplinary team. That's what I do in my hospital over there. Right. So checking all these things, the blood eosinophils, the pheno levels, and if the asthma is clinically allergen-driven, etc. If the answer is yes, probably initially you will have to consider a non-biological therapy. But if the answer is no, you will have to review the basics, like the differential diagnosis, the inhaler technique, the adherence to the medication, presence of various comorbidities, why the patients are not taking any medication, is it because of the side effects of the drugs or any other factor like the cost of the drugs, etc. Avoid exposures which probably precipitate the symptoms. Consider various investigations like this if they were not already done, and consider add-on therapy, like you can probably start with a trial of tiotropium or a macrolide. Stop ineffective therapies. There is no point in continuing with any ineffective or partially effective therapies. Consider low-dose oral corticosteroids in these patients. If the answer is no for any of these things. On the other hand, I was talking about the answer is yes, you will have to consider non-biological therapy. So consider increasing the dose of inhaled steroids for 3 to 6 months. I would be happy if I go up to the dosage of 1600 micrograms of budesonide or its equivalent. Consider adherence test, and you have to consider definitely ADP, nasal polyposis and atopic dermatitis. And then check is an add-on type 2 biological therapy is available and if it is affordable by the patient or not. I'm sorry, I do have quite some slides to go. Right. So if yes, consider add-on biological type 2 target therapy. I will rush through the slides. I think I'll skip those things over here. So consider add-on type 2 targeted biological for patients with exacerbations and allergic or eosinophilic biomarkers we dealt by the previous speaker. Consider the cost, dosing frequency, route and patient preference. Which biological therapy is appropriate to start first? So if it is anti-Ige or severe allergic asthma, probably you can think in terms of omalizumab. If not, anti-IL-5 or anti-IL-5 receptor. Probably if it is partly effective or ineffective, you can change over to the other one. Right, so what factors predict good response to anti-IgE or anti-IL-5? Anti-IgE, the blood eosinophils more than 260, pheno more than 20, and if it is allergen-driven symptoms, probably these patients are going to be benefited with omalizumab. On the other hand, anti-IL-5, high blood eosinophils, more exacerbations in the last year, adult onset asthma, and presence of nasal polyposis. So if eligible, try with the trial of omalizumab or trial of anti-IL-5 for more than 4 months. I have a cutoff of 16 at the maximum up to 24 weeks. If the response is good, probably we have to reevaluate the patient. If the response is not that good, you will have to stop the add-on and consider switching to a different type 2 targeted therapy. Right. So depending on the blood eosinophils, the serum total IgE and then the sputum eosinophil, we do have different phenotypes. Where if we have atopic asthma with eosinophilia, probably omalizumab might be a better choice. Atopic asthma, yes, omalizumab is a definite choice in this. So predictors of response, the previous speaker had talked about that. So omalizumab is nothing but a new class of agent directed against treating the cause of allergic disease. It's the first anti-IgE drug by stopping the free IgE binding to the mast cells, the allergic cascade is prevented, and it binds to the IgE at this particular domain. So mechanism of action, we all know the B cells through the epsilon swish plasma cells, and then there is a free IgE which combines with that, and then there is release of mediators causing allergic inflammation that causes bronchoconstriction, further exacerbation. So omalizumab blocks each and everything. For example, it reduces the high affinity receptors over here, so that causes probably a block in the release, and it also reduces mediator release and improves the symptoms and complications. It also blocks the free IgE and reduces the cell-bound IgE. So anti-IgE treatment, you can see it definitely downregulates the receptor expression of the epsilon receptors in this particular one compared to the pre-treatment done by the end of 3 months. So what are the various clinical consequences of blocking IgE in bronchial asthma? You can see there is a definite decrease in the asthma exacerbations, omalizumab in comparison to placebo, and not only that, there is a definite decrease in the OCS usage of those patients who are treated with omalizumab, and it also decreases the severe exacerbation rate, those patients treated with omalizumab in comparison to placebo, and it obviously improves the quality of life in those patients treated with omalizumab. So how do you select patients for omalizumab? I'll talk about that in the next one. So in case if you have to diagnose a patient and put in a diagnosis of severe asthma, if it is not obvious that the patient is not going to be a suitable candidate for omalizumab. On the other hand, if the patient is more than 6 years, controlled with ICS and LABA, multiple documented severe exacerbations, frequent daytime and nocturnal symptoms, and the FEV1 is less than 80% predicted, if this patient's skin prick test is positive or the radiologist abdomen test is positive, yes, depending on the body weight, less than 200, and the total IgE between 30 to 1500, these patients are definitely going to be good candidates for starting on omalizumab. Okay. So what are the various predictors in response, once you give the patients with omalizumab? I think those patients who are getting high dose of ICS, more than 800 micrograms of budesonide or its equivalent, or those patients having a history of emergency treatment in asthma for the past 1 year, and those patients who have an FEV1 less than 65% predicted, probably they might do better when started with omalizumab. So the integrated pathway, I think the previous speaker had dealt with this, the same thing. We talk about 2 studies. This is a study involving 800 odd patients over a 24-week trial. So that was the response to omalizumab 4 to 6 months after starting omalizumab in comparison to 1 year prior to starting on omalizumab. So the GET, the Global Evaluation of Treatment Effectiveness, scale at 4 to 6 months post-treatment. You can see 67% of the adults rated excellent or good responders for the GET. 77% of minors rated it as excellent or good responders, and 68% of the patients with high eosinophil count have rated that as excellent and good responders.
Sorry to interrupt you, Dr. Sorry to interrupt you. Can we come to the conclusion? We are actually running 1 hour late actually.
I understand that. I'll come to that, sir. And the 4 or 5 slides for me. Okay. So the third criteria was this: a combined response showed 58% of the adult responders with high blood eosinophil count and 58%, the same thing, of adult responders with low eosinophil count. So that means to say, high eosinophil or low eosinophil, you have proper markers. Most of these patients can be started very safely and effectively on omalizumab. Right. I'll talk about the Indian thing. This was done in Kerala. So this was a retrospective study based on the hospital records. Patients with uncontrolled asthma, despite systemic evaluation and correction of modifiable factors, were considered for the study, and they were assessed for the suitability to omalizumab therapy based on the allergic status, body weight, and the IgE range. And of those who were given good candidates, patient perspectives and acceptance rate was assessed, and then the reasons for refusing the medication omalizumab therapy was also checked. So approximately 560 patients were taken into account. Of that, only 51 patients had truly severe asthma and qualified for omalizumab, because based on the body weight and the IgE levels. And then only 50 of these 51 patients offered therapy with omalizumab. Only 16 patients took omalizumab and 35 did not take it. And the mean duration of therapy and asthma control noted in the 16 patients. And then the asthma control by the end of 6 months was assessed. So what were the various reasons for denying omalizumab in those patients? You can see erroneous feel or feeling good. So that is not only good in this particular thing. Most of the diseases where the patient feels symptomatically better, they tend to stop the medicine, whatever you prescribe. So the duration of therapy, 14 out of 16 patients wanted the clinician to allocate a fixed time, and the mean duration was about 8 months, and 12 patients settled for 6 months, and 2 patients continued beyond 1 year. And then the reasons for stopping therapy is this.
Sorry, very sorry to interrupt you.
Yeah, the last slide, sir. So all patients had improvement in asthma, all the 3 parameters like the ACT, exacerbation rate, and then the main systemic steroid use on a daily basis. There was improvement in parameters of all these things. So significant clinical improvement even after stopping the treatment, and also good control over the exacerbation rate. So to summarize, omalizumab is the first anti-Ige therapy for management of persistent allergic asthma. It blocks the free IgE, it downregulates the receptors and decreasing the mediator release. And it's an add-on to the regular therapy, ICS and LABA, for chronic use only. It is not for acute use at all. And the efficacy and safety, lots of evidences are present on the efficacy and safety. And there are clinical evidences to say it should be assessed after 16 weeks of therapy, and markers of response or asthma control, exacerbation rate, lung function, and the usage of oral corticosteroids. Thank you.
Thank you very much, Dr. Balamurthy. We'll have the questions at the end of all the 3 talks. Maybe we can have a few questions. And the next 2 talks are recorded talks. I have the pleasure of introducing Professor Emilio Pizzicini, who is from Brazil actually. He is a professor of respiratory medicine at Santa Catarina Institute in Brazil, and is the head of Lupaiva Asthma Center, and he is the head of pulmonary division in HU Florianopolis in Brazil, and he is the South America's lead of the respiratory effectiveness group. He was also the past member of the GINA Scientific Committee from 2006 to 2017. And he had received so many international awards and has published in reputed journals. And I request the organizers to start the recorded talk.
Good morning. My name is Emilio Pizzicini. It's my pleasure to be participating in this Severe Asthma Summit organized by the Yashoda Hospitals. And my task today is to discuss about mepolizumab in severe eosinophilic asthma, evidence and experience. I would say that's not a warfare, but it's a discussion about drugs that can be used in treating patients with eosinophilic asthma. Those are my conflicts of interest. I am from Brazil, from the city of Florianopolis. I am a global medical expert from GSK, so I'm a GSK employee and professor of medicine in my university. We are going to speak today about personalized medicine with the use of pembrolizumab. This has been a trend that we are still in the way to reach the end with all the gains about precision medicine. And the most significant knowledge that we have gained is about biomarkers that are able to identify patients that can respond better to treatments. And these biomarkers, they can be prognostic, predictive, or diagnostic. I think the data that I'm going to present with mepolizumab relies on 3 pillars. The first one is innovation. So mepolizumab was the first anti-IL-5 drug to be released and investigated in severe eosinophilic asthma. Has understood what would be the best biomarker to be used in clinical practice. I'm going to start to show also the consistency of the results. That's very important in a way that you can take your decision. So from the first studies that we have decided the population, the right population of patients that are able to respond, our results shows the same endpoints. And finally, I will run out with studies in real world that can increase the generalizability of the application of the results of mepolizumab in your clinical practice because your patients are different. So the choosing the right patient came with this very small paper that took 2 years to be published in the New England Journal of Medicine, where 19 patients with severe eosinophilic asthma that were prednisone dependent were randomized to receive placebo or mepolizumab on top of standard treatment. And 4 questions have been asked in that study. So can we decrease exacerbations? Can we have a prednisone sparing effect? Are we able to have biological plausibility with decreasing of biomarkers? And finally, can we improve patient-reported outcomes? And the answer for each single question was positive. So we are able to reduce exacerbations, no exacerbations that were eosinophilic in mepolizumab, 50% reduction in the dose of prednisone, 80% reduction on biomarkers, and improvement in symptoms and FEV1. The biomarker used in this study was butyl, but it was highly correlated with blood eosinophils. So the next study that has been designed was the DREAM study to assess the dose of mepolizumab to be used in clinical practice. And this dose is 100 milligrams every month. But most importantly, was designed to find out what would be the best biomarker that we could use, and finally, what would be the dose that we should, the cut number for eosinophils to discriminate responders and non-responders. From all this bunch of biomarkers that have been measured, only 2 reached an analysis that was able to see. And finally, they also undertook the decision to find out what was the best platform to find out patients that would have benefited from mepolizumab. And this reduction in exacerbation that was tested was 30%, and this has been proven with a number of 150. It means that you have a patient that has severe asthma, using 1,000 micrograms of fluticasone or more, many of them using prednisone, and they still have 150 eosinophils in the circulation. When those parameters have been used to select patients in the cardinal studies, mepolizumab, which is an antibody against the ligand IL-5, is able to reduce constantly exacerbations, decrease the OCS use, improve lung function, improve quality of life, and have long-term effects. We are going to show a few results about this approach. So the Columbus study has evaluated patients that have been included in the DREAM study and followed for 4 years, and you can see that the main outcome, exacerbations, has been reduced and maintained over 4 years. The second observation is that it's very important that you are not able to reduce all exacerbations with LEPO. You are only able to reduce the eosinophilic exacerbations, and non-eosinophilic can still occur, and they might due to other causes. During this 4 years follow-up, there was no concern regarding the safety. In another study that took the patients from the serious study, so patients that were prednisone dependent, so patients with severe asthma, and they had been following the COSMOS and COSMEC study to understand how much prednisone patients would eat by the end. Message from evidence-based medicine that we should apply the results of trials if the patients are similar. And a way to have similar patients is to have real-world studies trying to address the question in your population, in your patients, and your clinical setting. And this has been adopted by REC and also by GINA, even though the application in the guidelines for these changes has not occurred yet. In this slide here, I show the results of 8 studies that have been already published and that have evaluated in countries like Australia, UK, Italy, France, and globally the effectiveness of pembrolizumab. And you can see that in 1,300 patients, the reduction in exacerbations population is around 79%. The reduction of OCS dose is 62, and 51 were able to stop prednisone in this situation. I'm going to give you a glimpse of 2 studies that are highlighted here: the Global Reality A study and the French AQ study. So the French AQ study was designed when LEPO was launched in France, and it was a 2-year follow-up study of patients with severe asthma. And you can see that in the previous 12 months, there was 5.8 exacerbations per patient per year, and there was a reduction in exacerbations of 86% in first and second year. If you look at the patients that have been prednisone dependent, 40% of the population, 65% of the patients were free of OPS after 2 years. And finally, I think this is, the most relevant of the study because it's a multi-tender global study that's ongoing, that has been carried out in several countries in Europe and North America. So it's 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 Europe and North America. So is that Europe and North America. So is that Europe and North America. So is that Europe and
audiovisual team, please. Audiovisual team.
Europe and North America. So is that
This talk will be followed by the next talk on Bendalsmab. We know that there are no head-to-head trials between Mepolizumab and Bendalsmab. It will be interesting to listen to the next talk on Bendalsmab, which will give us some insights as to where we should prefer Mepolizumab over Bendalsmab or Bendalsmab over Mepolizumab. I will request my co-chair, Dr.
I have the pleasure to introduce Professor David Jackson from UK. He is the head of the Severe Asthma Center, Guy's and St. Thomas NHS Trust, UK. He is professor at King's College of London, consultant in severe asthma and eosinophilic lung diseases. His areas of expertise include asthma and precision things like EGP, Church-Strauss vasculitis, eosinophilic lung diseases, adolescent asthma transition care. So requesting the audiovisual team to start his recording, please. I think this is the last session of pre-lunch.
Hospital in London, and also an associate professor of respiratory medicine at King's College London. My pleasure today to present to you about optimal targeting of eosinophilic inflammation in severe asthma using Formulations. These are my disclosures. I want to begin by highlighting the fact that we've really known for a long, long time how critical the eosinophil is in asthma. These are two publications, first in 1975 and then in 1982, really describing the eosinophil role. So in 1975, Hall wrote that the total eosinophil count reflects asthmatic activity, is useful for regulating the steroid dose and for the early detection of exacerbations. Then 7 years later, this very important paper in the Lancet described the striking blood and tissue eosinophilia in asthma, the relationship of eosinophilia to severity, and the release of the granular contents into the damaged tissues that really highlighted the role of eosinophils in damaged airway. We know that many patients may not appear to be eosinophilic when they're stable, but you take those same patients during an exacerbation, reduce their sputum, and you see that the majority have eosinophilic sputum, either purely eosinophilic or mixed with neutrophilic inflammation as well. We know that there's a clear relationship between the blood eosinophil count and the risk for the patient. The higher the blood eosinophil count, the greater the risk of an exacerbation, the more difficult it is to maintain good asthma control. So now we're in a situation, a very fortunate situation, where we have multiple biologic therapies that can control the T2 inflammation that is so central to severe asthma in a way that doesn't harm the patient like systemic steroids do. We have omalizumab that targets IgE, and we have mepolizumab and bezlizumab that target the alpha-5 cytokine, and benalizumab that target the alpha-5 receptor. I won't talk about the other biologics that are emerging, like dupilumab and tezepelumab, because of time today. So just thinking about these therapies, what we know is the higher the blood eosinophil count, the greater the benefit when we target the eosinophil directly. This is a post-hoc analysis that I performed looking at the relationship between the blood eosinophil count and exacerbation rate. In the placebo arm, you can clearly see that the higher the eosinophil count, the greater the risk of exacerbations happening. But when you target the eosinophil directly with benralizumab, that effect size increased, the greater the eosinophil count, the greater the effect size. And this is totally different from what we see with IgE. And this is a very important take-home message, because often physicians see an elevated IgE and think, oh, we must target the IgE, we must give patients anti-IgE. But this is simply not the case. Because what you can see here is even in patients that had an IgE of 500 or 1,000 or even 2,000, if you target the eosinophil, the efficacy, the effectiveness in terms of reducing exacerbations was exactly the same. Because fundamentally what you need to target is the eosinophil. And I think this comes across when you look at real-world data for omalizumab as well. What we're seeing here is almost 3,000 patients treated with omalizumab in Japan. The top row is the year exacerbation rate, the year before, bottom row, the year after omalizumab. Whilst there is clearly a proportion of patients who do well with omalizumab, what this data tells us, which is what I see every day in clinical practice, is that if you target IgE, there is a significant proportion of patients who continue to exacerbate. In fact, what we see here is more than 40% still have 2 or more exacerbations, more than a quarter still have 4 or more exacerbations, despite having the right phenotype of severe allergic asthma, despite being sensitized to various perennial era allergies. We did an analysis of guide which we published in the ERJ earlier this year, which took 230 patients from our centre who had completed 1 year with either benralizumab or necessitates. We looked at the outcome, the effectiveness of treatment, depending on whether or not they were also eligible for omalizumab. And what we saw, and what we're presenting here, in the top left, panel A, which is the exacerbations with survival panel, our proportion of patients who are exacerbation-free. Panel B in the top right, the weaning of systemic steroids on treatment. Panel C, which is change in asthma control, or panel D, which is change in lung function. Whichever outcome measure you look at, the effectiveness of targeting the eosinophil is totally independent of whether or not the patient is also eligible for omalizumab. What we know from the omalizumab studies is the reduction in exacerbations is modest rather than fantastic. We also know that there are no controlled studies showing the ability to actually wean systemic steroids in patients on prednisolone every day with omalizumab, which is why panel B here is so important. Because what we know from both mepolizumab and benralizumab is you take atopic, sensitized subjects who are on systemic steroids. If you target the eosinophil, you can get them off systemic steroids. And the most recent study which demonstrated this was Phenotypes, which was published only 1 week ago or so. This had almost 600 patients on systemic steroids given benralizumab. And what I've highlighted here, the middle cluster, the bar chart here, are the proportion of patients who were able to totally stop their prednisolone. Or if they needed some prednisolone, it was only for adrenal insufficiency, not for their asthma. And you can see that 80% were able to stop prednisolone. But what is perhaps even more impressive is that this happened, and yet 75% stopped having exacerbations. So let's think about now the difference between mepolizumab and benralizumab. The mechanism of action is different. One targets the cytokine, one targets the receptor, and this is fundamentally critical, which you can see on the right, because of the magnitude and the speed of reducing the eosinophils. This is work from the Oxford group, Angie Moran, looking at the effect of a single dose of mepolizumab in blue, or benralizumab in orange, or prednisolone in green. You can see by 4 hours, just like with prednisolone, you see an incredible reduction in eosinophil counts, down to about 30 or so from the starting point of around 800. By a month, which is the time of the second dose, it's even lower, it's somewhere between 10 and 20. Mepolizumab is affected by the second dose. You can see here that you're still got counts between 1 and 200. And the speed of onset of benralizumab is clinically relevant. And we can see this when we look at the phase 3B Andy study shown here. You can see the change in lung function already by 2 weeks, which is really quite remarkable. But it's not simply about the speed, it's about the magnitude. Some people say, well, it doesn't really matter whether you only halve your eosinophil count or whether you need to deplete it altogether. But actually there are clues that for some patients, the reduction in the eosinophil count with mepolizumab is simply not sufficient. And I think the clues actually first were evident in the steroid-sparing studies, the serious study for mepolizumab compared to the Zonda study for benralizumab. What we saw from the serious study was that despite treatment with mepolizumab, the exacerbation rate was still 1.44. Now you could say the patients were more severe maybe than in the other studies, and that's the danger of always doing an indirect treatment comparison. So how does one compare in the absence of a head-to-head? The key is to look at the placebo response, because if the placebo response rate is similar, then fundamentally the patients are similar in the two studies. What we see here, the placebo response is actually 2.1 in terms of exacerbations. In the Zonda study, it was 1.8. So 2.1, 1.8, pretty much the same, approximately 2 exacerbations. Yet, with a serious study on mepolizumab, the exacerbation rate was still 1.44. With Zonda on benralizumab, it was 0.54. A third of that. There's a 70% reduction in exacerbations overall compared to a 32% reduction with mepolizumab. We also see on the one-year extension studies clues as to the clinical relevance of actually depleting all eosinophils, or the vast majority, compared to only approximately a 50% reduction in bone marrow and the airway, which is what we know happens with mepolizumab. So this is the Cosmos study. And we see an exacerbation rate on treatment in the one-year extension of 0.9. And 54% were completely exacerbation-free. The same study was done for benralizumab, or the Bora study, but rather than an exacerbation rate of 0.9, and there's at 54% being exacerbation-free, we actually see an exacerbation rate of half that, at 0.46, and 74% are exacerbation-free. Why might this be? Well, interestingly, there was a recent study published in the Lancet Respiratory Medicine, GSK-sponsored study called NEX. Fundamentally, this study was to identify what an exacerbation is when you are already on mepolizumab. They found something very, very important. They identified that half of the subjects who were exacerbating on mepolizumab were still having eosinophilic exacerbations. The other half were predominantly having bacterial events, they were neutrophilic. In some ways, they weren't even true exacerbations, but they were clearly non-eosinophilic. What I think underpins the difference between these rates we see in the Zonda and Sirius study, the Cosmos and Bora studies, is that these exacerbations that are eosinophilic on mepolizumab probably aren't actually happening on benralizumab because you simply don't have any eosinophils in the area left. And to look into this further, when we first had access in our centre to benralizumab, we switched patients who had already completed a year of mepolizumab and not had a sufficient response to benralizumab. And this is data we published last year in Allergy. On the left, this is a cohort of 33 patients who first had mepo, then had benralizumab. You can see on the left, the first bar is the exacerbation rate the year before mepolizumab, which was around 4. After mepolizumab, or at least at the end of the year of mepolizumab, which was still around 4, which is, of course, why these patients did not respond and why we wanted to switch them. But then when we switched them to benralizumab, the exacerbation rate, whether we measured it at 6 months or whether we measured it at 1 year, was below 2, so more than a 50% reduction. In the middle, panel C here, you can see this is the percent reduction in maintenance prednisolone. The majority of patients who are unable to significantly reduce their prednisolone with mepolizumab from this cohort, there were others that did, this is a specific cohort of suboptimal responders, were able, when you switch them, to then come off prednisolone or reduce by a significant amount. And the change in asthma control you can see on the right, where there wasn't a sufficient improvement in asthma control as recorded by the ACQ on mepolizumab, but when we switched these patients to benralizumab, we saw a very marked improvement in symptoms day to day. And this was measured at 6 months, it was measured at 1 year, it told us the same information. We now have data going up to 5 years of benralizumab. There's always a discussion, often by competitors, around the safety of eosinophil depletion. I think this study puts that concern to rest. We've now got 5 years of data. Over 5 years, the event rate of serious infections was less than 2%. The event rate of malignancy was less than 1%. What we see here is a remarkably low exacerbation rate from year to year across this period. So to summarize, directly targeting sniffling inflammation with pembrolizumab leads to significant improvements in asthma control and lung function versus placebo, which we see as early as 2 weeks after the first dose. And this is from the Andy phase 3B study recently published. We see reductions in maintenance steroids that allow approximately 80% of patients to totally come off systemic steroids for their asthma, just from the Penente data published last week. There is no controlled data supporting efficacy of anti-IgE in OCS-dependent patients. It's a very important point that often gets forgotten. It's, in my view, inappropriate when you have a patient on maintenance of permisolone to start them on omalizumab if you have access to a drug like benralizumab or mepolizumab. When you directly target the eosinophil, there is equivalent efficacy irrespective of atrophic status, the IgE level, or co-eligibility for anti-IgE. So these are the overlap patients. They're atopic, they're eosinophilic. Doesn't matter in terms of the effectiveness of a drug like mepolizumab or benralizumab. If you target the eosinophil, whether it's allergy or non-allergic drivers to the eosinophilic inflammation, the patients do just as well. The exacerbation rate reduction we see in the phase 3 studies of anti-IL-5 and 5 receptor drugs is greater than what we see in anti-IgE. Benralizumab leads to reduction in asthma exacerbations, which is consistent with this 5-year treatment period we now have available and published. And what's really remarkable is that more than 70% of patients each year were completely exacerbation-free, which really, again, highlights quite how central eosinophil is in asthma biology. And on that note, I'd like to stop and thank you for your attention.
If you have the permission of the organizers, we take a couple of questions. So, just a brief comment on the talk actually.
Hello, my name is Dave.
It's very softly put that benralizumab might have an edge over the mepolizumab in terms of reducing the number of exacerbations and the number of more. He says that more number of people are able to feed off oral corticosteroids, and he has said that there are no major serious infections or malignancy risk in patients who are treated with benralizumab. I don't know in our setting where there are a lot of parasitic infections and other things, whether a complete depletion of eosinophils would be the same, would lead to any kind of things we need to see in the coming years. And I invite comments from Dr. Raja and Dr. Salvi sir regarding that actually.
So, I think I touched on this, Vishwanath, when I spoke. I think we still don't know what's the choice between partial and complete depletion. We don't know the answer. We don't know whether partial depletion actually means you're actually destroying the homeostatic eosinophils and hence causing more damage, or whether there's selectivity in destroying eosinophils when you're destroying. Yeah. So, if you're sort of preserving the homeostatic eosinophils and destroying the inflammatory eosinophils, then partial depletion makes sense. If you're actually trying to deplete a bit of both, then it doesn't make sense. We don't know for sure. I think in both the talks that you saw, there was a bias in favor of either of the two molecules, if you see, right? So one spoke more in favor of Mepo, the other spoke more in favor of Benra, and you can now actually argue in favor of either of the two molecules as things stand today. The major challenge is how do you select your patients between Mepo and Benra? We heard Deepak speaking about this and he does this beautifully. But even with the phenotyping that you did, you will have a lot of overlap population. So what I currently do, just because I've used Mepo for much longer, is to use Mepo in patients with eosinophilic asthma. If these patients are not stable or keep having exacerbations for 4 to 6 months, I would probably resort to Benra in these patients. If I can do a sputum eosinophil in these patients and find more than 3% eosinophils, it will push me further in favor of Benra, because I would think total depletion might work better in these patients as compared to partial. It's not evidence-based, but that's what I do practically in my clinic.
And even the dosing frequency, the mepolizumab would be every month, and then pembrolizumab would be every 2 months.
So the first 3 months, it's once a month, and then it's every 2 weeks, like you said.
I would agree with what Dr. Raja said. Eosinophils are there for a good reason in a human body, and so are IgE. They're useful. So completely blocking them with monoclonal antibodies to cure the asthma may have adverse effects which we're still not aware of. So the point that you raised, I think, is very important, especially in a country like India. We need eosinophils to take care of those parasites and even air pollutants. Eosinophils play an important role, and so does IgE. So until we have those long-term studies in our country, I think we should be a little careful about using these monoclonal antibodies.
Thank you very much.
I would like to thank the speakers for helping us understand this complex fold of biology in severe asthma. I would like to call on Gangadhar Reddy sir to provide mementos to the speakers and the chairpersons. Dr. Balamurugan sir, please. Dr. Alimuddin sir, please. Dr. Vishwanath Kella sir. And Dr. Lakshman Babu sir. As we are running behind schedule, we will have the session on bronchothermoplasty later in the day. We will now break for lunch. I request the faculty and the practicing pulmonologists to proceed for lunch. I request the postgraduate students to stay back for a severe asthma quiz. There are several exciting prizes to be won, so you don't miss the chance. I would like to call upon stage the quiz master for the day, Dr. Nagarjuna Matlu sir.
Before we leave, I think we will reassemble at 2:15. So because for the case discussions, we will be having the international faculty live, and it will be an interactive session, and that is where I think we will learn the max. We have 3 live cases, so we'll meet at 2:15 again for the case discussions. And I request the PG students to come forward a bit. How many are there? Can we have an answer? If you have any of your friends outside, also ask them to come. It's just a 10-15 minutes.
Hello?
Quiz.
हो गया प्राइस डिस्ट्रीब्यूशन.
Can anyone see the questions?
हो गया ऑलरेडी.
No, it is there. I think the delegate kids have the answer sheet.
ना प्राइस डिस्ट्रीब्यूशन हो गया ऑलरेडी. उसके बाद टिल्ट किया.
This is only for the students, not for the practicing pulmonologists, and not for students from our branch. So we have 15 questions. Each question has two sub questions. So we have to answer both of them. And each correct answer will do 1 mark, and we have some star questions to decide our tiebreakers, and our decision will obviously be final. Please mention your name so that we can announce for the prizes also. Is everyone inside can see, because we have some images also. If you can't see, you can just come front. Okay, so we'll start for each thing. Okay, we'll start. The first question is this. It's basically true or false. All of them are based on severe asthma. So are the statements true or false? First thing is, all severe asthmatics have uncontrolled asthma. Second, all uncontrolled asthmatics have severe asthma. I will just give 30 seconds for this. So basically you have to understand the difference between uncontrolled asthma and a severe asthma. I think this much is sufficient. Go to the next question. 30-year-old female were presented with history of progressively worsening cough, breathlessness. She had allergy, she had wheezing. She was treated on antibiotics, antihistaminics, ICS, LABA, despite which her symptoms were not resolving. This is one of the cases where it come to us in OPD. So these were the X-rays. So the diagnosis was evident on the X-rays itself. You have 5 X-rays here. You can see at varying courses of time. First, second, third, fourth and fifth. So what is the diagnosis? First question is what is the likely diagnosis? Second, which investigation will help us to confirm the diagnosis? So basically this lady who had wheezing, cough, expectoration, this is the serial X-rays. Are the X-rays clear? Third, what is the minimum inspiratory flow rate needed for the following inhalational devices? It is very important for us to know about this. So we have this breath actuated MDIs in our country. We also have this DPIs, turbo inhaler. So I would want you to write the correct number and the unit also. So for a breath actuated MDI, what should be the minimum inspiratory flow rate which is needed? And part B is for a DPI. So each DPI has a different inspiratory flow rate requirement. So for a turbo inhaler, which is there for several years and which is there in our country also. So what is the flow rate which is required for drug delivery? Okay. Fourth question is, this is again interesting. I think you have heard about the talk on omalizumab. So the question here is very clear. By what pathophysiologic mechanism does omalizumab lead to the following beneficial effects? Persistence of clinical benefit even after discontinuing the medicine in a subset of people. So even after stop the medicine, the effect may be prolonged after stopping the medicine. So what is the pathophysiological mechanism? Second, reduction in viral infections. It has also been shown that omalizumab can decrease the viral infections and seasonal viral exacerbations in children. By what mechanism does omalizumab does this? Just a couple of words on each of these. One of which was spoken by the speaker, the second one was not told in the talk. So I think you should have read it to answer the question. This again is a start because this is an interesting question on pathophysiology of omalizumab benefits. Then again, this is a very practical question. This Dr. Vishwesh was talking. If you are keen in his talk, you can answer this thing. 3 case scenarios. I won't be reading all of these things, but you have Ig levels, Aspergillus fumigated specific Ig levels, serum eosinophil counts, sputum Aspergillus, X-ray, CT, and severity of asthma. So a case A, case B, and case C. Which case has ABPA with bronchiectasis and which case has severe asthma with fungal sensitization? You just have to identify and write. This again is practically relevant because we have a lot of cases who come to us and we do these investigations. You have to actually stratify them so that you can decide on the therapy. Then sixth is, you should have heard the talk in the morning. By interpreting impulse oscillometry report, all the following indices for measuring small airway obstruction except R5 minus R20, AX, FRES and R20. So this is an except question. All of the following are indices for measuring small airway obstruction except. Because now impulse oscillometry will slowly be launched at multiple centers, it is important for us to know about impulse oscillometry also. Then this is a lady who had presented to us with breathlessness and wheezing. Wheezing was the main symptom. She was diagnosed to have asthma and was being treated for the same. She developed hemoptysis when she had come to us. So this was the CT. Hope the CT is clear. So what is the likely diagnosis? Person with wheezing comes with this sort of a CT and has hemoptysis. and mutation in which gene can cause this condition. Choosing a biologic. So both the questions were covered in the earlier speakers. Which is the only biologic which is approved for use in children aged between 6 and 12 years? So we have 3 biologics in our country: O'Malley, Macaulay and Bengali. Which is the one which is approved for use between 6 and 12 years? Second question is, if the absolute eosinophil count is 240 cells per cubic millimeter, which is the anti-IL-5 or anti-IL-5 receptor biologic that can be considered? You have different eosinophil cutoffs for using anti-IL-5 biologics. So in this particular person, the eosinophil count is 240. So which you would fulfill the eligibility criteria for which anti-IL-5 biologic? Then this is again an easy question. 2 non-contrast CT scans of patients with severe asthma. 2 different patients, not the same person, are shown below. You can see here and here. So what is the name of the radiological sign which is described? 1. And 2. What is the radiological definition of the sign? So how do you actually define that sign? You have to get both the answers correct. The first part is easy, but second part also you have to tell. What is the radiological definition of the particular sign which is being described? This is again very clinically relevant thing. Again, this was covered by 2 speakers. So list 2 clinical characteristics of a severe asthma that is eosinophilic driven and hence likely to be responding to anti-IL-5 biologic. So when you take history and look at the person, if the person has these clinical characteristics, you would call it as a eosinophil driven asthma. So any 2 clinical characteristics, there are 4 or 5 which have been listed. So just write 2 of them. This is very important when you're looking at a person with severe asthma. Then again, one question on impulse oscillometry. The following is true about oscillometry indices: resistance values are frequency dependent, reactance values are frequency dependent, AX measures large area obstruction, and resonant frequency of 20 Hz is normal. So you don't activate the right middle lobe. So if you do a biopsy, do you find reduction in muscle thickness in the right middle lobe also? Both are true or false, sir. The last question on neurobiologics. So I just wanted to name the newer biologics. We have heard a lot about O'Malley, Mapoli and pembrolizumab. So there are more in the pipeline. So name the molecule which blocks anti-thymic stromal lymphoprotein, anti-TSLP. So TSLP basically lies way up in the cascade. So basically if you can block anti-TSLP, you can block the whole inflammatory cascade below. So this is, we have some papers published also on this thing. Probably we'll get phase 3 trials also on this anti-TSLP biologic. Second part is molecule which blocks anti-IL-4, anti-IL-13 pathway. Some of the speakers were talking about this biologic also. Just want to name the biologic. They're all tongue twisters, but then it is important for us to know that. I think that's all. So now students who have answered, I would request them to come and keep the answer sheets just on the desk so that we can correct. All the PG students, whoever have answered, people are still writing. I think the quiz is over. I'll request them to, or someone can collect the answer papers either way. Shereen can help in just collecting them. Yeah. I think you can go have lunch and then we'll again probably meet up in half an hour at 2:15 to have the clinical case discussions.